Good morning, everybody. Welcome to the BAPM Perinatal Update, which is about to start. My name's Hilary Adams and I'm the BAPM President, and I will be chairing this meeting this morning, which is very much focused on neonatal neurology this time. So we've got some fantastic speakers for you this morning. I'm really delighted that they've all been able to make it today. And I'm also delighted that about nearly 300 of you have asked to participate and have signed in. So not all of you are on the call just yet, but I'm sure many will be joining later. Our first speaker today is Dr. Shetty Bhushan, who is a neonatologist and clinical lead at the Nine Wells Hospital and Medical School in Dundee. And he's currently chair of the Consultant Forum for the National Neonatal Network in Scotland. He's got a very keen interest in perinatal neurology and adaptation at birth, and he's been involved with the Scottish Cooling Group from its inception. And he's going to be talking today about the implementation of the BAPM cooling framework in Scotland. So welcome, Shetty.
Thank you. Thank you for the kind introduction. Good morning, everyone. For the next half an hour, I'm going to look at Scottish collaboration in the implementation of BAPM framework of practice of therapeutic hypothermia. So we're going to look at the framework when it was updated. We have set up a Scottish cooling group since 2010. We're going to talk about progress. And we do take annual reviews and audits for the last 10 years. I'm going to share the data from the last 5 years. And then we're going to talk about how we implemented the updated BAPM framework. BAPM published framework for practice with the aim of expanding and updating previously published BAPM position on therapeutic hypothermia for neonatal encephalopathy in 2010. This was in light of a new research and evolving clinical practice in UK. Investigation, management, and treatment of neonatal encephalopathy is a very important area of practice with potential for lifelong implication for babies and families. Reduction in newborn and neonatal brain injury is a key national objective, and there is no number of strategies have been implemented to support this. So the expert group developed a framework for practice, and which was updated and published in November 2020. And we're going to, and this has a basis for our update and implementation. There are a few points in the updated guidelines. There were clear section on criteria provided. They advised against cooling mild hypoxic ischemic encephalopathy, and they provided some evidence base for that. They suggested cooling can be done in between 33 to 35 week gestation, and sudden unexpected postnatal collapse might be acceptable if the parents are appropriately counseled, but the caution of lack of evidence and the risk exist. And treatment of clinical seizures only if there's electrical correlation, and spectroscopy along with the MRI in a timely fashion for prognosis to predict the prognosis. So we mapped our current pathway with the published updated 2021 and specifically about established transport service with ongoing servo controlled cooling for the ongoing care of the baby ongoing therapeutic hypothermia to be done in NICU. Network should have a network-wide clear pathway of care, and network should monitor, audit, and benchmark with the incidents. We were doing all this part, but the updated part, what we wanted to implement was all neonatal care settings in special care baby unit, local neonatal unit, and neonatal intensive care unit should be able to assess, instigate therapeutic hypothermia, use of cerebral function monitoring, and servo control equipment, which was outlined. And all networks should explore the use of telemedicine to support decision making for the referring unit. So this were the two main things we wanted to implement and support. So we looked into evidence for support of change. We noted that outborn babies started cooling later and reached target temperature later than the inborn babies. We also looked into evidence base. The outborn babies have more severe hypoxic ischemic encephalopathy grade, more MRI injuries than inborn babies, and more likely to die. And, and recently published in the archives for looking at National Neonatal Research Database of over 5,000 babies from 2011 to 2016 from the UK database. What they concluded was moderate and severe hypoxic ischemic babies who are born in the center without immediate access to therapeutic hypothermia, less likely to survive without seizures, frequently arrive in NICU beyond the 6 hours, temperature outside the therapy treatment range, and more likely to be overcooled. So Scottish cooling group has been established in 2010, where cooling became the standard of care, and it's been well represented by all levels of neonatal care providers, including ScotStar, which is our national neonatal transport service. We have established care pathway for transport as well as for the units. We organize regular study days, which was more frequent in the early part, now yearly ones. We undertake cooling audit with the help of Natalie Sim, who's been running the audit for the last few years, looking at cooling standards as well as service standards, and shared learning across by discussing grey cases on an annual basis. In Scotland, we have here is two maps here. One on the left side, we can see that in the neonatal side, we have 15 neonatal units, mainly in the central belt and the east coast, whereas the maternity services covers a wide area provided in 43 maternity units across in 14 territorial health boards. So it's quite trained. So it does come up with a challenge to produce. The cooling center, as it marked here in the red color, in the blue color, were the current provisions for cooling centers. We do take regular audits looking at the cooling standards and the service standards as below. So I'm going to share some data from the last 5 years. We cool around 50 infants per year in Scotland, and the incidence has remained nearly 1 per 1,000 live birth. We are aware of the data, and some of the other data sets represent the incidence is going down, and they made some good quality improvement program. We are looking into how to improve our service and gestation and weight as below. We identified targeted temperature when it was reached. 90% of them, nearly 90% of them reach the target temperature within 6 hours after being born. We do have babies who are overcooled. When we look at the temperature for inborn and outborn for the targeted temperature, we have noted that the things are improving, but still the variation exists. We have stepped up in educational resources about the understanding of Dakota mattress, and that has helped us to improve as the years pass by. We are looking at neurodevelopmental follow-up from 2017 and 20. It's a work in progress, but this is the immediate outcomes I'm sharing from 2017 to 2021. In the last year, in 2021, we had nearly a quarter of them die in the immediate period. What's concerning, where we want to improve, were infant not meeting criteria were cooled. There were insufficient evidence of acidosis or low UPCAs or need for continued support in the early part of the study period. And when it comes to mild encephalopathy, we noted that nearly, and it still persists. It's improving, but still there. We know that it's not uncommon to find the similar around 10% of a Japanese register between 2022 to 2016. When they published the data, they also suggested around 10% of the data were mild hypoxic ischemic encephalopathy. So we had a mapping exercise with multi specialist and multidisciplinary meetings looking at how best to improve our care, and we addressed in 6 streams here as aligned. We look into one by one. We aligned our current Scottish cooling pathway and published therapeutic cooling decision aid, which helps referring center as well as the cooling center to go through the path for proper documentation, for the ease of documentation, and to follow the pathway. For the ongoing management, we subdivided in the second graph to general management and for the temperature management in specific, and ask them how to seek help and how to avoid overcooling or undercooling. Documentation was a key part, and to aid the documentation in the timely interval of assessment, we made them a management aid for transport team so that they can document it and electronically transferred. We worked with the Scottish Government along with the national procurement after option appraisal and feedback from users. The equipment have been standardized to Tecotherm servo control cooling and brains monitor for ease of training, upskilling, and to share the data. And they've also helped us producing videos for equipment use, which I'll share later. We do organize regular study and update days. We are very lucky to have input from PIPs from the charity. Sarah, who's going to join us later, will tell us how the charity is working. They helped us join in for the study days to share their stories and to support us. We did specific days during the handover times or new staff induction times to upskilling part of it. We regularly review the current available evidence and pathways and update our Scottish neural cooling pathways, and we host them on our Scottish Perinatal Network website, which is an open website, and most of the Scottish networks and the neonatal units are familiar of this website, ease of using them. It does have aids which that can be printed. They can also view and upskill and use the videos for training staff. We do have same place the 3 animation video, which I'm going to talk about later. Remote consultation has become a part post-COVID, and we are all getting good at it. So we do encourage and use a two-way communication, a virtual consultation between the referring center and the cooling center, mainly about neurological examination and about cerebral function monitoring and interpretation to help them to gain confidence over a period of time and to discuss the ongoing care provided. With the help of nurse and input from highly skilled animators, we're able to produce 3 animations, which we use it for training and during study days, as well as they're present in the portal for the referring center can use, including the cooling center can use for training the staff. The first one being neurological examination. The second and the third are supporting clinic communication skill, one about diagnosis and treatment. The second one about prognosis and ongoing management. I'd like to show a short clip from each of the videos and take questions from there. I have to step out of this presentation. I hope you can. This is the first video. I'll share the QR code to get into the videos. First video about neurological examination.
In mild encephalopathy, a baby may seem hyper-alert, and small changes in the environment will cause the baby to have a high-pitched cry and be irritable. Pain and other conditions should be considered as alternative causes of irritability. Babies will usually lie in a flex position, and they may appear wide-eyed and staring. There may also be a fast respiratory rate. In moderate encephalopathy, a baby lies in a frog-legged or extended position. They may not move without handling and will be slow to wake when disturbed. They may show distal flexion of their fingers and toes and have a weak cry. The respiratory rate may be irregular and they may require ventilatory support. In severe encephalopathy, a baby with normal tone should have a straight back and lift their head in line with the body. The limbs will be flexed. A baby with low tone will feel as if they may slip through your hands. The back will be curved and the limbs will hang straight. Assessing the Moro reflex should not be undertaken in ventilated babies. In all babies, secure lines before undertaking this assessment. Hold the baby in a semi-supine position facing you. Support the head lightly and drop the head and upper trunk by a few centimeters. In a normal response, the baby will startle and show symmetrical abduction and extension of the arms, followed by symmetrical adduction and flexion. In a weak response, there will be some extension but less flexion, and the eyes will be slow to open. If the
So that was about neurological examinations. I showed you small clips over there. And the second we use for communication.
An unwell newborn breathe, we are worried that this could be a sign that your baby suffered a lack of oxygen to the brain.
So we'll start from first. Sorry, it's skipped.
An unwell newborn is a very worrying time for new parents. We've put together this short video with the help of parents to assist you in thinking about how and what you might say during those early conversations. It is essential to reassure parents as soon as possible after birth that their baby is alive and receiving treatment. Introduce yourself and find out the parents' preferred names. Congratulate them and find out their baby's name. Tell them you want to explain what has happened to their baby and what will happen next. Explain in simple terms, using plain language what has happened. Take time. Allow pauses. Find the language which is natural to you. You may want to say something like, "Your baby wasn't very well when they were born. They needed lots of help to breathe. We are worried that this could be a sign that your baby suffered a lack of oxygen to the brain. Your baby isn't responding in the way we would expect. This makes us concerned that your baby's brain may be stressed by what has just happened. There are lots of reasons why this may have occurred. We are performing a number of tests, but we often do not get a clear answer. It may be appropriate at this stage to introduce the prospect of the baby not surviving, if that is relevant in this case. It is important to get across that therapeutic hypothermia reduces but does not eliminate chances of long-term problems. You may say something like, "Cooling treatment can help babies. By cooling the body temperature down by a few degrees, cooling reduces the chance of further injury to the brain, but this treatment does not help all babies." Cooling treatment involves a special machine to keep your baby at a lower temperature for around 3 days. During this time, we will give medicines to keep your baby comfortable. For referring unit purpose, reassure parents that their baby is receiving medication to keep them comfortable. Emphasize to parents that intensive care treatments and monitoring will be continued in the ambulance and at the destination hospital. Parents say that introducing and explaining the term hypoxic ischemic encephalopathy early on is helpful. They also say that focusing on the practical elements of how they can be involved in their baby's care is important. Tell parents they are essential in caring for their baby, and how talking or reading to their baby may be a source of comfort, even when their baby is sedated. Explain that they may not be able to hold their baby for the first few days, but that touch and containment holding will provide comfort for their baby. Describe how parents can also be involved in changing nappies and giving mouth care. Explain how mother's milk will be important for their baby's tummy when feeds start.
That's what about communication in the first part. And the last animation is about sharing.
Meeting with parents to discuss prognosis is a key moment in their neonatal journey. To this meeting, they bring hopes and fears for their child and their future, and will remember key phrases for life. Remember, you are discussing their baby, not just the MRI, and while parents value honesty, they seek compassion too. It is therefore really important to approach this meeting with preparation, information, and support. Ideally, the clinician who meets with parents should be the same person involved in the care of the baby. If not, find out what has already been conveyed to parents by reading notes and speaking to other members of the team. Before speaking with parents, make sure that you are familiar with the MRI report and have had the opportunity to discuss the significance of the changes seen with any relevant members of the team. This may include staff from any of these groups. Seek first the parent's understanding and information needs. In discussing the MRI result, use simple language and explain any necessary medical terminology, such as hypoxic ischemic encephalopathy. Explain how the MRI is a part of the jigsaw that is considered along with other factors such as the severity of asphyxia at birth, the neurological progress, including that of the AEEG, and growth and development over the coming months. It is important that parents understand that it can be difficult to predict the severity of impairment at this stage, that not all damage seen results in long-term injury, and conversely, a normal MRI does not guarantee a normal outcome. Not all MRI results fall into classical patterns of injury, but where they do, use your own words to convey these key points based on classical patterns of hypoxic ischemic injury. For a normal MRI, this is positive news. While this is reassuring, around 2 out of 5 babies may develop mild problems later. These problems with learning and behaviour may be seen at school age. It is important for parents to be aware of this when their child starts school, so that teachers can provide support if it is needed.
Hope you guys are able to view the animation with the sound. I hope it went smoothly. So here is the QR code, and it's a open resource, and you can download. I'll leave it on the slide for 2 minutes, and we'll share that videos. Sorry, I was able to just play some clips because of a time constraint. So we do have these 3 animation we use for training, and we are ever grateful to Sarah Land and the PIPS charity who helped us to give feedback during the process of creating this animation, especially during communication skills, both the animations. The work is ongoing. We are currently working along with the NHS Education for Scotland to have a TURAS model and a LearnPro model so that the staff can be able to, maternity and the neonatal staff able to do the learning model. We have subdivided into science and evidence part of it. Then selecting patient for therapeutic hypothermia. We have a good section with the input from neonatal staff, from the transport, as well as cooling and the referring center about how to care for the baby early on and the ongoing care. And communication skills will also have been put into the post. It's due to be published, completed work in the final stages in summer of 2023. We hope to see that. So we started off, Scotland has its own challenges, and you can see this number of boards where, although it's 14 boards, number of sites where maternity service provide is quite expanded. geographically widely distributed, and current cooling centers are here, and referring centers are being upgraded, and more centers are able to provide the starting cooling with servo control, and they also procured with the central provision of cerebral function monitoring and able to upskill the staff to establish cooling early on. Thank you. Thank you for your time and happy to take any questions. I would like to thank Sarah from a PIPS charity who helped us, also NHS Scotland Education Board and the Procurement Board. We host all our resources on Scottish Perinatal Network website, and thanks again.
Thank you very much, Shetty. That was a great talk and so much interesting material being produced in Scotland around this. So, and very interesting to hear about your results of your audit as well. That was great. Oliver, I thought your question was relevant. Do you want to just pop your hand up and ask about the about your audit question?
Yeah, thanks very much. Excellent. So much really good information there. Those resources are amazing. There's so much good stuff coming out of Scotland for quality and safety. It's always impressive to see. Lots of people are making various pathway documents for all sorts of things, and HIE is a key one. Have you audited use of the pathway, just in terms of getting the balance between making it comprehensive and keeping it simple and usable? Thanks.
We haven't audited the use of pathway, but during the process of pathway being established, we do circulate for reviews and feedback. We do hear lots of it. Goes to different version. I think the last one was some 17 version before we finalized. So we do have lots of input before the pathway is established. And people, when we have grey cases discussion on an annual basis or during our audit review meetings on an annual basis, we do hear from the users how we can tweak and improve, how to make it user friendly and way to publish it. And we have improved as the stages go by, but not systematically undertaken the use of pathway. It's something we can do. We'll try to do that.
Thank you, Oliver. Have we got any other questions? If you'd like to raise a question, then please put your hand up in the hands up place for us to ask. While people are thinking about that, I wondered whether you had, I don't know how long those resources have been out there and people have been using them, but have you seen an improvement in or a reduction in the number of babies with mild HIE that are undergoing cooling as a result of having the examination videos more standardized and things? Has that made any difference?
The pathway was BAPM framework of practice were published in November 2020. So we started our work in 21. So waiting for the 22 data sets to come in. We have asked for the data set. We are very lucky to have Natalie Sim, who's one of our specialist register and senior register, who's been undertaking the audit for the last few years. And she has already sent us the second reminder to submit the audit at the 1st of February. So she's very timely, and we'll have the data soon. We'll have the data soon. Yeah.
And I may have missed it in that last slide, but are you also planning to do some animation around the AEEG? I don't know what the situation is with all of your units now got the brains monitors, and how well is that going, do you think, in terms of diagnosis and support across the region? Is that monitored by your cooling group?
The plan is to monitor. Currently, it's been a steep learning curve and upskill for people who are not used to looking cerebral function monitoring. Even for people who are used to cerebral function monitoring, if the equipment change, it's a display changes or how we set up, hard getting used to the system. But we have some screenshot of general trends wise and how to part of it. We are encouraging referring centers to come back and use Microsoft Teams to have a direct input, one-to-one input during the process. So if they have any concerns, they can update about placement of the electrodes, or if there is any artifact they have noted, how to get clarity among that part. We are work in progress. We have published our user guide, and as well as how to set up serval function monitoring, how to put the electrodes, what are the pitfall, and what are the things to look for as a part of a video, and we host that in the Scottish Perinatal website.
Fantastic. Thank you so much. It sounds like you're doing so much work on this, and it's really, really great to hear about all these resources which you've made open access for others to use as well. So really, really very well done on doing that. It sounds absolutely fantastic. Are there any final questions for Shetty before we move on? Anyone else want to ask a question? No, thank you very much, Hetty. That was really fantastic.
Thank you, everyone.
Thank you. So we'll be moving on now to Ella, Ella Chakrapani is an associate professor in neonatal neuroscience at the University of Bristol, and he's also a consultant neonatologist at St Michael's in Bristol. And he has a very keen interest in looking after families of babies with brain injury and understanding brain development following perinatal brain injury, and also looking at interventions that may be helpful to improve those outcomes. So he did most of his training in Bristol, and he also moved as a postdoc period to the University of British Columbia in Vancouver. He has expertise in translational research, clinical trials, neuroimaging, and developmental follow-up. And he's also an excellent speaker, I know from previous experience. So welcome, Ella, who's going to talk to us about what we need to know about neuroprotection in 2022. Thank you.
Thanks, Hilary, for those kind words. I've just made a minor change in the topic as 2023, given we are in 2023. Right, let me see if it works. Okay, so I'm going to just give you a story about where we are with the neuroprotection and in babies who have sustained hypoxic ischemic encephalopathy, and how we support parents, and what are the current data with additional neuroprotectants along with hypothermia. And during this, I want to learn from you guys as well. So if I could please ask you to open a window in your computers and have menti.com open. I may have a couple of questions where I can learn about the current practice. Okay, in terms of population, about what I'm going to talk about, this talk is about term babies who have sustained hypoxic ischemic encephalopathy, and all the data pertains to high resource settings. And these are term infants who are born at or about 36 weeks gestation, and they have defined exposure to perinatal asphyxia. Following that, the babies have developed encephalopathy, which is usually confirmed with brain activity suppression measured using CFM or AEG. Okay, neuroprotection. So can I please ask you guys to go on to this menti.com and then use the code which is on the top. I just want to understand what the word neuroprotection mean to each of you. Let's just leave this open for 20 seconds or so. Okay, I've got few coming in, so I shall just switch the slides to menti.com so that you can see as well. So the predominant word which has come up from all of you guys is cooling and protecting the brain and future as well. So yes, let me try and touch upon all these topics in the next 20 minutes or so. Let's go back to our talk. So as you've highlighted, the neuroprotection has the word itself has different interpretations. If we ask researchers, the brain is just not made of neurons. There are other cells as well, which are important cells, oligodendrocytes, which helps with the myelination, microglia, which mops up the inflammation after hypoxic ischemia, astroglia, which provides nutrition to the neurons. So we need to protect all those cells as well as neurons. So a purist will say neuroprotection is an inadequate term. If you look at the clinicians versus researchers, again, somebody could define neuroprotection as a neonatal brain MRI which does not show any evidence of injury. And the clinicians will think about having children develop normally without any motor disability, not such as cerebral palsy. And the developmental clinicians will think about how is their global development in terms of their cognitive skills, language skills, and motor and adaptive behavior. So those are all the different perceptions of the word neuroprotection. What does parents want? How do parents perceive the word neuroprotection? Is there some work done on it? Parents, what they want to know, can my child meet or exceed the developmental milestones? Can they walk? Can they run? Can they jump? And one of the predominant thing which comes up is, can they be happy and healthy? Can they speak? Can they independently feed and thrive? Would they have any early learning issues? And the key thing which comes up often is, even if they have disability, will they have a good quality of life? Which is something really difficult as clinicians to reassure them about quality of life. And if you look at all the literature, how the neuroprotection is defined in clinical trials, it's about survival, looking at neonatal brain MRI and ensuring there's no brain injury, and some data coming about using general movements assessment at discharge and 3 months of life, if there are any fidgety movements and cerebral palsy, and if they have cerebral palsy, how severe it is. And he used a system, gross motor function classification system, level 1 being the mild severity and level 5 being a severe end of the spectrum. And looking at the developmental assessment, it's a cognitive composite score from a Bailey neurodevelopmental assessment. And the papers in the literature has different thresholds. 85 is one standard deviation below the mean for the population. Less than 70 is 2 standard deviation below the mean. And it's usually defined as severe disability if it is less than 70. The current literature is using less than 90, for example, and that is involving even children with milder impairments, and vision and hearing. So we want to encapsulate all these components of development as neuroprotection. So we all know, and you heard the talk before, what is a current neuroprotective intervention? These are the 3 lines. This is it. For the babies with HIE, 3 days of therapeutic hypothermia with a temperature maintained at 33.5, and it's commenced within 3 hours of birth. Yes, our guidance is 6 hours of birth, but if it is commenced before 3 hours of birth, there's better motor development. That's what the data says. And the key thing is the optimal intensive care. Providing cooling without an optimal intensive care is not going to do a great job in protecting the brain. So why, it's just a quick recap. How cooling came into practice. This is a slide summarizing data from all the clinical trials. The x-axis shows the clinical trials and the y-axis shows the primary outcome of mortality and disability. The red bars are babies who were not cooled, and the blue bar are the babies who were cooled, and the dark color denotes mortality, and the diagonal lines denotes disability. And you can see the hypothermia group is consistently lower than the normothermia group. So if we look at it, around 40 to 50% of cooled infants still had death or disability. So there was more work to do then. This was in 2010. So then clinical trials looked into how can we improve the outcome in cooled infants. One of the things which they looked at is, can we cool longer or can we cool deeper? Which is, longer means, can we cool for 5 days or can we cool down to 32 degrees centigrade? This trial had to be stopped halfway through because of concerns of futility. And also what happened was, you can see the data on the left side shows a survival curve, and the top line is the group which were cooled for 3 days at 33.5 degrees, whereas the rest of the group are down below. So there were concerns at discharge that the rate of death is increased in longer or deeper cooling. And that was confirmed in the later follow-up that babies who are cooled longer tend to have a higher risk of death compared to babies who are cooled for 3 days at 33.5. And there's also concerns about adverse effects. For example, on the left side, here you see the babies who are cooled longer, shown by the dark blue bar, and the babies who are cooled 3 days, light blue bar. Interestingly, the babies who were cooled on 3 days had increased incidence of major bleeding, whereas there's arrhythmias and anuria in the longer cooling group. And if you look at the deeper cooling, again, the deeper cooling is shown by the dark blue bar, and the normal 33.5 degree group is shown by the light blue bar here. The deeper cooling, there's increased need for inhaled nitric oxide. Babies ended up in ECMO more frequently, and they had bradycardia as well. So the optimal hypothermia was decided after those trials, and there were lots of animal studies which have informed the optimal hypothermia regimen as well. The depth has to be 33.5, and the duration is 3 days. So if you look at the outcome of death or moderate to severe disability, so that there are on the x-axis you have 3 days of cooling, either at 33.5 or 32, and the 5 days of cooling at 33.5 and 32. Yes, this trial was stopped early, so it doesn't have sufficient power to answer this question. But even then, if you see here, there is no significant difference between the primary outcome between these groups. So we are stuck with 33.5, 72 hours. That's the optimal treatment. We often face, thankfully not frequently, babies who present with seizures at 12 hours or 13 hours of age. Their criteria, they didn't fulfill the criteria A, they were not encephalopathic, and then they were taken to MRI after the seizures. They have extensive brain injury consistent with the hypoxic ischemic injury pattern. So what do we do? Do we cool or not? So this was addressed in this late cooling trial, which randomized babies for cooling for 96 hours, not 72 hours, 96 hours. And they were randomized anywhere between 6 to 24 hours, and then either cooling or non-cooling. So if you look at the traditional way of analyzing this data, the frequentist approach, so the normothermia group is shown here and hypothermia group is shown here. And the primary outcome in the y-axis, death or disability, there's no significant difference. But the trial investigators used a Bayesian approach, which we can look at the next slide. Here it is. So they used a Bayesian approach with a neutral prior, the blue curve, which is saying that, okay, hypothermia does not have any effect. And then using that prior, they used the data from the clinical trial and then calculated the posterior probability, or the probability that hypothermia will be helpful. And they came out with this graph which shows about there's a 76% probability that a delayed cooling might be beneficial. But there is, again, a rest 24% harm as well. But then there's another paper which came out criticizing this approach, that if you look at this red curve here, the neutral prior could be a skewed distribution. And if it is a skewed distribution, then it comes out that there is no difference between hypothermia or normothermia. And again, this dotted line here shows that if 2 babies from hypothermia group developed adverse outcome in the trial, then there is no difference. The reason for this paper from ACTA is animal studies have consistently shown that if cooling is delayed beyond 12 hours, there is more brain injury rather than brain protection. So I think it is fair to say that what we know at the moment is it may or may not reduce death or disability. That's a conclusion we may reach. But clinically, we will face these babies, and that's why BAPM, we said we may have to cool these babies. And the key thing is optimal intensive care. Yes, we talked about cooling quickly. If we cool within 3 hours of age, then there is an improvement with motor development in the babies. And we don't want to have any temperature above 36.5 degrees centigrade. Hypothermia is shown to negate the protective effect of hypothermia. So no hypocapnia. I know there are babies with severe encephalopathy will drive their PCO2 down because of the metabolic acidosis. That is the physiology, and we can't do much about it. But there are babies with moderate encephalopathy. If you're ventilated, you need to make sure their PCO2 is about 35. Hypocapnia is associated with decreased developmental scores. And avoiding hyperoxia. When we are resuscitating, some of these babies are, we may have to increase the oxygen to 100% during cardiac compressions and try to bring that down, because in the Bristol data, we have shown that if babies are exposed to higher oxygen the first 6 hours of life, then there is an association with death or disability. Identifying seizures and treating them is good data showing that seizures, independent of the severity of encephalopathy, is associated with brain injury on MRI. Avoiding stress, animal data suggests that stress during cooling will eliminate the protective effect of cooling. Yes, there is lots of data around using morphine, whether we should use morphine, is it going to worsen the outcome? So far, the studies have shown that using morphine delays the hospital admission, but it hasn't been shown conclusively to impact the developmental outcomes at 2 years of age. Maintain hemodynamic stability. There's good data coming up showing that babies with HIE have right ventricular dysfunction, and that is associated with brain injury. And blood pressure is not a good marker of monitoring right ventricular function, and these babies may need echocardiogram and supporting with inotropic support. Hypoglycemia. These babies are vulnerable on, and they do develop hypoglycemia or hyperglycemia sometimes. Ideally, these babies need continuous glucose monitoring in the subcutaneous tissue, picking it up and treating them, because hypoglycemia adds on to brain injury, which happens with hypoxia. So we have shown magnesium is important as well. Hypomagnesemia is associated with impaired brain energy metabolism in these babies. So, it's a package doing the optimal intensive care and cooling. And that's what will help with the improving the outcomes. So outcomes with cooling therapy. Right. I think we have time for this slide. I just want to understand what is the current practice with a follow-up. Can I guys ask you to go to the menti.com and put your preference in how you would rank these statements with regards to follow-up? Okay. So the topmost is follow-up and global developmental assessment at 2 years of age, regardless of neonatal MRI findings. And the next one is follow-up until 6 years if 2-year developmental scores less than a mean. Right, that's yes. I think most of the networks and most of our clinical colleagues will do the first one, following them up and doing a developmental assessment at 2 years. Excellent. Let's go back to the presentation again. So there we go. That's the top one. Right. So this slide summarizes the outcome of all the cooled babies from the clinical trials on the left and the contemporary cooling cohorts on the right. But this bar is the data from the late cooling trial. It's not a cohort study. What is obvious is, the dark blue bar, the dark blue component of the bar denotes death, and the diagonal lines denote disability. And you can see the death has significantly gone down. This Dutch cohort is an anomaly, but the rest of the data you can see, since hypothermia became standard of care, death has gone down. But if you think we have changed the practice of withdrawal of care and that babies ending up more disabled, doesn't seem to be. If you look at the component of disability, it is around 25 to 30, 25%, and that remains stable compared to clinical trials and contemporary cooling cohorts as well. Why is that? Because one of the arguments is, hey, you guys are cooling mild babies with mild encephalopathy. That's the reason the outcome is better. Let's look at that. So on the left-hand side, I've here in the bottom graph, I've given the distribution of babies with moderate and severe encephalopathy. The moderate one is light red and the severe one is dark red. Yes, the clinical trials had a significant proportion with severe encephalopathy. But then in the contemporary cooling cohorts, severe encephalopathy has gone down. The gray bar shows mild encephalopathy. Yes, there is some babies with mild encephalopathy being cooled. But if you look at here in the depth and duration clinical trial, there was no infant with mild encephalopathy. And if you look at the disability here, it's same. So the death have gone down, the disability remains, and the disability percentage is about 25 to 28%. We know the cerebral palsy has declined with hypothermia. And this is on the left-hand side. The first four bars are data from clinical trials. Dark blue shows death, light blue shows incidence of CP, and the severity of CP is given as well, 1 to 5. In the cooling trials, there was a uniform distribution of severity of CP, whereas this is data from Bristol. In Bristol, we saw either milder CP or severe CP. So what is clear is about 70% of survivors following cooling do not have CP. So what is the outcome at school age? And here, this is the data from the TOBY trial and NACHE trial. This is at 6 to 8 years of age. This cognitive outcomes. Interestingly, the NACHE trial, the cognitive outcomes are about the mean for the population, whereas in the NACHE trial, it was lower. And this included children who had CP. So we wanted to see what is the outcome of babies, the 70% of survivors who do not have CP in terms of their cognitive outcome. And we have shown that in a case control study where cases are children who did not have CP and underwent cooling for encephalopathy, they had an IQ, an average 14 points lower than matched controls. And if you look at the subdomains of their cognitive outcomes, they were all lower in cases. Working memory, verbal comprehension, perceptual reasoning, and processing speed, they were lower than the controls. And if you look at the proportion of children with IQ less than 1 standard deviation below the mean, again, in the case children, about 20% had that. So if you look into we imaged these children at 6 to 8 years, and we found they had impaired microstructure in the white matter tracts, which was associated with decreased cognitive function, like in the corpus callosum, and you can see here the internal capsule, anterior thalamic radiation, which are all in yellow in color. All these white matter tracts had impaired microstructure. So moving on to adjuvant neuroprotectants. So this is just data from the clinical trials. If we go into animal study, we have to talk the whole day. So there's a HEAL trial published late last year. So where we had two babies undergoing cooling are randomized to receive either saline or erythropoietin, 5 doses. The first dose started around 17 hours of age, and then day 2, day 3, day 4, and day 7. So here the primary outcome, death or neurodevelopmental impairment. It's not moderate to severe disability. It is neurodevelopmental impairment, defined as cognitive score less than 90. There's no difference between hypothermia or EPO plus hypothermia. If you look at death, so again, the EPO group is this purple, hypothermia is blue group. There's There's no significant difference in the death. So this is a traditional way of assessing disability, moderate to severe neurodevelopmental impairment. There's no difference. Interestingly, EPO group had more externalizing problems compared to the hypothermia group. If you look at the adverse events, the investigators reported the total number of serious adverse events were higher in the EPO group. And this more than one standard serious adverse event was higher in the therapeutic hypothermia with EPO group as well, although individual adverse effects weren't that different. So xenon was used in the phase 2 trial. 30% xenon was given for 24 hours. It was started at around 10 hours of age in cooled babies. Here, this is the MRI biomarkers on the left. Blue is the hypothermia group, and green is the xenon plus hypothermia group. The MR biomarkers, lactate NAA ratio or fraction isotropy, did not differ. The death at 2 years by 2 years of age did not significantly differ, and moderate to severe disability is no difference. Human umbilical cord blood cells, the 4 infusions were given and babies were randomized. Again, this is a phase 2 trial between cooling and cooling plus umbilical cord blood cells. There's no difference in the survival, but there was marginal difference in children with Bailey scores greater than 85 in the stem cell group compared to hypothermia. And this is the numbers you can see. It's only 46 children. So there's no phase 3 trial yet. And melatonin plus hypothermia, and this is a systematic review published looking at a smaller phase 2 trials. There is no difference in the death between cooling versus cooling plus melatonin. If you look at the developmental outcomes shown on the y-axis, there is, again, the numbers are really small, 11 babies in each group. The hypothermia plus melatonin shown in the orange bar may have a slightly better developmental scores. N-acetylcysteine and vitamin D, which is particularly useful in animal models of chorioamnitis and hypoxia. That's been tested in a phase 1 trial, and that showed, because it's mainly antioxidant, all these neuroprotectants have anti-apoptotic, anti-necrotic, or antioxidant, neurogenesis, angiogenesis, multiple mechanisms of action. So NAC plus vitamin D increase the glutathione in the brain, which is an antioxidant, and decrease the plasma isoflurane, evidence of antioxidant effect. Apart from children who had genetic syndromes and SIDS and lost to follow up, the 24 babies who survived tend to have normal outcome. So where are we? This slide is courtesy from my good friend, Professor Heyman from Bonn. So what do we do now? These are all the neuroprotectants tested in a rat model, and the x-axis shows all of them, and the y-axis shows the brain area loss. So the lower the number, better the brain protection. The blue one shows the hypothermia, where we are, and the agents on the left tend to have better neuroprotection. Interestingly, caffeine turned out to be the best one, followed by sonic hedgehog agonist and allopurinol. So what happens when we combine with cooling in high resource settings? We don't know. It's a challenge. Why? Because all these neuroprotectants have a competing mechanism of actions. And when cooling does it all, there is not much left for the other agents to do. And we have seen the incidence of moderate to severe disability has gone down to about 29, 28%. So there's not much room to show a significant difference with others. Timing of the additional interventions, when do we introduce? We may have to introduce later. And the translation from bench to bedside is often difficult. So how do we look after parents and the nursing care? So we did a cool cuddle intervention where parents can actually cuddle the babies during cooling. Because the cognitive score is impacted in this group, a better parent-infant bonding might improve the cognition in this group. So what we have published, we've showed that during cooling, during cuddling, there's about 0.07 degrees raise in rectal temperature for 2 hours, and that's not clinically significant. And there was a blood pressure which went up by 4 millimeters after cuddle. But the rest of the intensive care, mean airway pressure and heart rate seemed stable. And we also found that the end-tidal CO2 went up marginally after cuddle. Here is a mother-infant bonding score. The lower the score, better bonding. There's, although we had a distribution closer to zero, there are still mothers who reported higher scores indicating lower bonding. One of the worrying thing is the postnatal depression. This is the EPDS score. The score above 13 is indicative of depression. And there's, if you look at the distribution, there's quite a few mothers who are reporting postnatal depression at 5 to 7 days and 2 months, although it declined by 2 months. With Cool Cuddle, nearly 2/3 of families, parents, mothers were breastfeeding at discharge compared to the national average of around 50%. So in summary, I've taken you a whirlwind of a story about neuroprotection for babies who have had hypoxic ischemic encephalopathy, and how follow-up is crucial to be sure that we have achieved neuroprotection in those babies. And also, ongoing support for parents is crucial to help as a family for enhancing the cognitive development and brain development. Thank you. That's acknowledgement to all the parents, babies and children, and our researchers and funders.
Thank you very much, Ella. Fantastic talk and squeezed a lot into half an hour for us. That was great. We're running a little short on time for a question, but I've probably got time for one question if anyone wants to raise a hand. No, so I'm going to ask you one thing. Oh yes, sorry, we have got a question.
I had my hand up. Sorry, very quick question. Andre Morgan, thanks for a wonderful talk. It was really great to hear and see. You mentioned very briefly that caffeine was a potential. Can you say any more about that? Because it's something that we use in extremely preterm babies and obviously has impact on the brain. Are there trials ongoing, or are there thoughts about it? Or can you just say a little bit more about that, please?
I think in animal models, caffeine on its own, particularly in kind of a late preterm models and even in term models, had comparable brain protection with hypothermia. What we do not know is if we combine both, whether it'll be beneficial. So caffeine is something which could be in a lower and middle income settings where hypothermia may not be, it's not beneficial. But I'm not sure what's going to happen in the high resource settings. There isn't any trial planned as far as I know.
Thank you very much. Thank you. That was fantastic, Ella, and a really interesting run through what's happening. And as always, a very exciting area for ongoing developments and research. So thank you very much. So we will be moving on now to talk about mild HIE and cooling. So I'd like to welcome Sudhin Thayil, who is a professor of perinatal neuroscience at Imperial College in London, having had a previous period as a senior researcher at UCL. And his research is focused on prevention and treatment of neonatal encephalopathy. And he's the PI on several large multi-center studies and has extensive publications in this area. He's very passionate about supporting and mentoring early career researchers, particularly those from disadvantaged backgrounds and from ethnic minorities. And Thayil is the joint PI of the COMET trial, along with Professor Sita Shankaran from the United States. And he's here today to talk to us about cooling in mild HIE. Welcome, Sudhin.
Thank you, Ellery, and thank you, BAPM, for giving this opportunity. Let me share my screen. Is that on full screen now?
Yes, it is. Thank you.
Okay. Yeah. So yeah, like Ellery said, I'm the joint PA of the recently funded COMET trial, which you're hoping to start by end of this year in the UK. So this is the Hall of Fame in NICHD. So this is a photo from 1962, John F. Kennedy and his sister, Eunice Kennedy, a few years before the moon landing. And the NICHD was renamed in her name. Eunice is now called as Eunice Kennedy NICHD Hall of Fame. And if you look below that picture, there is another picture of a lady, doctor, called Sita Shankaran. So this was when the first cooling trial was reported, showing beneficial effects in NAGM in 2005. And that's a photo at the Times Square. And this is one of the first babies who were cooled. now at the time in going to university. Now, 17 years on, she got this landmark award, which is for interventions or RCTs that has lasted more than 15 years. So cooling has certainly lasted more than 15 years, and that was the landmark award. And if you look at most of the things we know about hypothermia, it's all from the trials Sudha Shankaran has conducted. So that's why I shown that slide earlier. Sorry, can you just go on? Yeah. So this was the original cooling trial, the NICHT cooling trial, standard cooling 33.5 degree within 6 hours for 3 days improves outcomes. That shown that in green box there. And then came the delayed cooling trial. Again, Siddha Shankaran and Professor Laptuk were the investigators. So if you cool after 6 hours, it's just because there are some babies who may not fit the cooling criteria in the first 6 hours and are not cooled. And if they're cooled within 6 hours, the benefit is much lesser. There is still some benefit, like Ela explained, but of course it's lesser than starting cooling within 6 hours. Then the optimizing cooling trial. So if you cool for longer duration or deeper, it doesn't work. So here you can see the red boxes, the diamond point estimates showing no harm. So if you cool for longer or deeper, it's going to cause harm. And again, if you use cooling in LMIC, it's again going to cause harm. So the last one, Sudha Shankaran and I were the co-investigators. So this was the largest cooling trial ever conducted, recruiting 408 babies from South Asia. It showed cooling was not beneficial and was causing more harm. Now, if you look at, there's been no study specifically looking at babies with mild HIE, but we did a meta-analysis some time back, pulling out babies who were accidentally recruited into trials of moderate or severe HIE. So there were around 100 babies, and when we pooled that data, there was no beneficial effects either way. We can't exclude harm or benefit from cooling babies with mild HIE. So this is not just an issue for the clinician. It's not about just having a dilemma, clinicians having a dilemma. It's about a treatment we are offering to parents and babies. We need to know whether it's causing harm or benefit. So that's what I'm going to talk about. I'm going to talk a bit about the outcomes after mild HIE, and then we'll talk about some of the registry data on babies who are cooled, mild HIE babies who are cooled, and then I'll share some of the data from the recently completed or just completing COMET pilot randomized controlled trial, and I'll explain you the design of the upcoming main COMET trial, phase 3 COMET trial. So if you look at the outcomes at 2 years, so this is one of the studies where we are also involved from Imperial College, mainly many centers in the US. So these are babies with mild encephalopathy who are not cooled, 63 babies, and then were followed up until 2 years of age. The loss of follow-up was quite high, almost 20% were lost to follow-up, but only one baby progressed to have seizures after 6 hours and then went on to have cerebral palsy. So overall, the incidence of motor issues after mild HIE is pretty low. In this study, 2 babies also had autism, but we can't really relate autism to HIE as such. But the hit seems to be mainly in the cognitive function. And this again has been very elegantly shown by a series of studies from the Cork group by Deirdre Murray. So these are again babies with mild encephalopathy who are being compared with control babies, and babies with just perinatal asphyxia without encephalopathy. So you can see the cognitive scores here, 97.6, is around 5 units lower than the control babies and also the babies without encephalopathy. So the cognition is taking a hit at 2 years. And as the child gets older, that seems to increase, and almost 38% of these children require special educational needs at a school age, compared to 18% of their siblings or none of the healthy peers. Why is that? It may be because the injury in mild HI is not to the deep nuclei where you'll have motor difficulties. It's mainly in the white matter and to hippocampus, which becomes more apparent as the child grows. So the child is actually growing into the disability as he or she is growing. So there is a definite clinical issue with babies with mild HI at a school age. Now, we have a lot of data we got data from almost 7,000 babies now who have been cooled, or 7,000 babies with mild HI. Many of them have been cooled. These are registries from the US, Canada, UK, and so on. So these data consistently show that cooling does increase the short-term mobility. There's more duration of invasive ventilation, more opioid use, more DIC, more hepatic dysfunction, more cardiac dysfunction, more tube feeding at discharge, more thrombocytopenia, more acidosis, and so on. So definite worsening in the short-term mobilities, which is fine as long as there is a long-term benefit. Now, if you look at the MR data from many of these studies are reported MR data on these studies with mild HI. The injury that we see is not main, is very different to what we see in moderate to severe HI. This is mainly in the white matter, mainly focal white matter injury and atypical patterns, not really classical of acute hypoxic injury. And interestingly, many of the babies, the key thing we worry about dealing with babies with mild HI is that whether they're going to have seizures or not after 6 hours. Interestingly, cooling does not, some babies do have seizures after 6 hours, but cooling does not seem to prevent that. And this is some MR spectroscopy data, a subgroup study from a large multi-center study we did called MARBLE. So we had looked at the data from 47 babies with mild HI. Again, some of them were cool and some were not. No much difference in our key biomarkers. Key MR spectroscopy biomarkers like NA and lactate NA were similar. And the Bailey scores at 2 years were again pretty similar. Some of the MR spectroscopy biomarkers were better in the cooled ones. So the jury is still out there. And if you look at the preclinical data, there is clear evidence that if you cool healthy brains, you can increase brain injury. You can cause apoptosis and you can increase brain injury. But then you might ask, why would I cool healthy brain? Would you? So this is the approximate incidence of babies with mild HI and birth acidosis. This is data from a Swedish database. They have this excellent population-based database in Sweden. So roughly the incidence of mild HI is twice that of moderate to severe HI. So like we heard from Shetty Bhushan earlier, the incidence of moderate HI is around 1 per 1,000. So mild HI will be around 2. And the incidence of birth acidosis, which we define as the criteria A in the TOBI trial, or pH called pH less than 7, is 10 times higher. So babies with birth acidosis but without encephalopathy are pretty common. And what do we do in the UK with those babies? So this is now quite old data from 2011 to 16. So of the 3,511 babies with mild HI, 30% were cooled and 66% were not, which is good. So therapeutic creep at that time, at least on papers, at least on records, it doesn't look to be as rampant, although this has substantially increased over time. But hopefully now with the new BAPM guidelines coming down again. But more worryingly, 830 babies without encephalopathy were also cooled. So these are the babies without brain injury getting cooled, and possibly we are causing more harm. And also the number of babies with moderate encephalopathy doubled over this period from 141 to 293. It cannot be that we've been missing babies with moderate HI previously, and it cannot be that the obstetric care has gone down in the past decade, which accounts for this increase. More than likely, this is a misclassification of babies with mild or no encephalopathy, especially when people overinterpret seizures, sucky movements on the tube, and baby get a dose of phenobarbital, and then classified as moderate and started on cooling. But the incidence of severe encephalopathy has remained same. So that's why BAPM has come up with a very important guideline. Many of you were part of it. And it recommends that we should no longer cool babies with mild HI, and clinical trials of mild HI are required, and babies should not be cooled outside such a randomized controlled trial. And that's partly the reason why we did a COMET pilot study, and now we got the funding for the main trial. So I'll briefly take you through the COMET feasibility trial data. We recruited 90 babies so far from 6 hospitals. There were 2 cohorts that were involved in the COMET pilot RCT. Cohort A was a classical babies, and babies randomized within 6 hours of birth, and then were randomized to usual care or cooling for 72 hours, which was fine. But often what happens is that, these babies get cooled in a peripheral center and are referred to the cooling center after 6 hours of age. And at that time, you lost the window to randomize. So those babies, we randomized to rewarming at 48 hours versus 72 hours of cooling. So essentially, there were 3 different arms, and you can see the temperature profile of these 3 groups below. Now, all these babies had a structured neurological assessment. You show this area in the very nice videos developed by the Scottish group and Chetty Bushen. So in the NICHT neuro exam, we classify babies on these 3 categories: level of consciousness, spontaneous activity, posture, tone, primitive reflexes, and autonomic system. This is a bit of a complex slide to understand, but essentially each column is a baby recruited to the COMET feasibility study. And the level of abnormality, neurological abnormality, is color coded from normal, mild, moderate, or severe. So the lightest one is normal. So, you can see here on the top one, not all babies with mild HE are just jittery and irritable. Many of them do have a normal sensorium, or occasionally they are lethargic as well. But they do have other abnormalities with spontaneous activity, tone, primitive reflexes, etc. So it is extremely important to do a very structured neurological examination by certified examiners to classify these babies accurately. And these are the short-term outcomes of the COMET pilot trial. So roughly 27 babies in normothermia, 31 in the hypothermia 48 hours group, and 32 in the 72-hour group. Very small numbers, but you can see progressive increase, worsening of all the short-term mobility. So more ventilation, more acidosis, more abnormal clotting, and so on. And seizures, occurring after 6 hours is no different, if not higher in the hypothermia arm. Of course, these numbers are small and is not statistically significant. And if you look at MR findings, again, pretty similar. No significant difference between the brain injury in the three groups. If with an eye of faith, the number of babies with normal MRI seems to be higher in the normothermic arm. So 52% had normal MRI in the normothermic arm, as opposed to 27% and 32% in the cooled ones. So this is the research question we are asking about in the main phase 3 COMET trial. Desk cooling or standard cooling 33.5 for 3 days. Is that going to improve your cognitive scores at 2 years of age compared with targeted normothermia? And the criteria A is pretty similar to the TOBY trial. So we had to have a recent evidence of acute hypoxic event, either low of gas or cord blood acidosis. And then on a structured neurological examination, it should not have moderate or severe HI, and the EEG should be normal. So abnormal EEG, that's the criteria for cooling in the TOBY trial. So we will recruit only babies with normal EEG or just absent sleep wave cycling and no seizures. And this is the intervention. Standard hypothermia. Control group is targeted normothermia for 80 hours. The randomization will happen at the birth hospital. So all hospitals, LNUs and SCBUs are eligible to participate. So they will screen, randomize, and recruit the babies, and then later on transfer the babies to a cooling center. So babies in both arms should be transferred to the cooling center and will get the same standard of care, including EEG monitoring for at least 24 hours. That's the primary outcome, Bailey's Composite scores at 2 years of age. So altogether, we are planning to recruit 430 babies from 40 to 60 NHS hospitals, so 2.5 years. That is around 3 to 5 babies per hospital per year. And this is the study flow chart. Babies will be screened at the birth hospital, and then using the structured standardized neurological examination and also EEG. And those with mild HI will be randomized to normothermia or hypothermia, and then both group will be transferred to the cooling center if appropriate for continued care, followed by an assessment at 2 years of age with Bailey. Study procedures are again quite intensive earlier on within 6 hours, and subsequently it's pretty minimal. And the follow-up is all centralized in the sense the central team will come out of the hospital and do the baby assessments. So the key work before the start of the common trial is developing a training and standardized examination a module for neurological assessment. And I'm so delighted to see the Scottish group is already way ahead in this with those excellent videos. And we also need to standardize the EEG and diagnose of neonatal seizures. I can probably make those kind of animated videos like we saw in the Scottish group. We also have a module on neurological examination in one of the MSCs at Imperial College, which we are hoping to use for this one. And like I said, the primary focus is going to be in LNUs and SCBUs. Of course, we'll include cooling centers as well, but the randomization need to happen at the birth hospital. So if you are a clinician for the birth hospital, essentially all the junior doctors need to be trained and certified on the neurological assessment, and the PI should be actively involved in the recruitment. Like I said, baby will be assessed clinically, and this will be video recorded for quality assessment. And then after parental consent, babies will be randomized. And if you are a cooling center or an NICU, you'll be a continuing care site for the outbound babies and will be a recruiting site as earlier for your inborn babies. Babies will have MR scanning before discharge and Bailey assessment at 2 years of age. These are the timelines. So we are hoping to start the study by end of this year. Recruitment once all the protocols and ethics approvals are available, and the recruitment will go on for around 2.5 years, and then 2 years of outcome assessment and the final data by 2029. It's just amazing how long these clinical trials take. So there's a large team involved. So Professor Sita Shankar and I'm the joint PIs, and Ronnie Pressler from UCL will be leading the EEG part of it. Professor Andy Shannon from King's and Sam Johnson from Leicester, and lots of other people, including health economics people from Oxford and Sarah Land from PIPS Charity and the CTU team. But the most important people are here in the red, because this trial, we plan to do this based on, we plan to use an ODN approach for the trial. So hopefully all the centers within each ODN, we plan to approach around 4 or 5 ODNs, they will participate. So a lot of work has already started at Kent, Sussex, and Surrey, which also is leading, and Ellery and John Darling from the Trent Tunbridge Wells ODN, and Ela from Bristol, and Bala Subramaniam from Liverpool, and so on. So it's a big team who are involved. So this is the summary of my talk. Mild encephalopathy is associated with marginally reduced cognitive scores at 2 years of age, but with markedly increased special educational needs at 2 years of age. And induced hypothermia is widely used for this condition in the NHS, but I'm delighted to see it is the drift is much less in Scotland. So the key work with the COMET, initial work will be to standardize the neurological assessment and seizure diagnosis, and the trial will provide a definitive answer for the safety and efficacy of cooling in mild HI. And this is something often people ask, is this trial going to overburden NICUs? I don't think it will, because we are cooling a lot of babies who don't even have encephalopathy at this stage. So, it may even reduce the number of babies who are getting cooled. And in any case, we are talking a small number of babies per hospital per year, so about 3 or 4 cases per year, which is not a huge burden. So as always, clinical trials are a big teamwork. There's some of my research team and some of the COMET collaborators there, Professor Andy Shannon, Sita Shankaran, Professor Ellen Grant from Harvard, in a meeting we recently had. Yeah, and thank you to all the collaborators and to all of you for listening. Thank you.
Thank you, Susan. That was a great talk and a great picture at the end there. I like that. Lots of interesting information there about mild HIE, a really important area for us to sort out. And congratulations on getting the grant to actually take forward this really important study. Have we got any questions from the audience for Sudin, please?
Susan, do you want to stop sharing because we can see your wider screen now?
Yeah, I'm just trying to stop sharing. I can't, seems to do that. Where is it gone? Oh, for some reason I can't stop sharing. Can you do anything from your end,
I'll
Larry?
take a look.
I think if you share something, it'll stop Sudin's sharing.
Yeah, I'll just try that.
Hopefully that will work.
Maybe I'll have to just go out and come back again. Oh yeah, gone.
Here we go. Brilliant.
Yeah.
Thank you so much. I think there weren't any further questions for you, Sudin. You obviously gave us so much information, and I think it was great to hear much more focus around the important topic of what we should or shouldn't be doing with our mild HIE babies. So thank you very much. That was really helpful talk. I'm going to move us on. And we're now going to be talking more about information for parents around babies with HIE. And I'm delighted to welcome Sarah Land, who is the co-founder of the PEEPS HIE charity, which she co-founded along with her husband, Steve, to try and raise awareness and to use her experience of HIE and the challenges that go with that to help other parents and to generally raise awareness around this issue with a particular parental aspect. So welcome, Sarah. Thank you.
Can you hear me and see my screen okay?
I can indeed. Thank you.
Wonderful. So yeah, thank you for inviting me along to tell you a little bit about us, share some parent voices and also the support that's available through PEEPS charity. Some of you might have heard of us. If you have, that's great. If you haven't, then hopefully the next kind of 15-20 minutes will explain a little bit more. And I'm always open to questions and to talking about what we do. So the experiences I'm going to share are some of my personal experience. I appreciate that is just one view of things. We've got feedback from families, so the families that we support through the PEEPS charity, and also to share about the charity itself and some of the ways that we can hopefully help support your families. I think just to start with, I just want to, I guess, give a little caveat that everything we talk about comes from a place of kindness. So if we're sharing feedback, there's certainly no intention for anything to be critical. We know that everyone is working really hard, everyone is doing things with the absolute best of intentions. It is just to give a different perspective and to share feelings from a parent's point of view. So just to give a little bit of background, I do share Heidi a lot, so you may have heard this story before, but she was born on Mother's Day in 2015. As we now know is often the case with HIE events, it was a really uneventful pregnancy, no indication that things could or would go wrong. And it turns out, we didn't know at the time, but Heidi had an unexpected postnatal collapse when she was having skin-to-skin time. And that was the cause of her HIE event. She's grade 3. She needed to be resuscitated, and that was really when our world changed very quickly. She had to be transferred for cooling therapy. And I remember a midwife at the time was saying that it was going to be a roller coaster. I don't think I appreciated just how poorly Heidi was. And that phrase stuck because that's so descriptive of our journey and so many others like us. So in total, we had 8 weeks in hospital. That was between the neonatal unit, back to our local level 2 hospital and then onto the children's unit before coming home. Heidi was still on oxygen, she was fully tube fed, she was having seizures, needed suction, a long list, but she was medically more stable. And I think that was when the fun kind of started when we got home, because we felt that we'd really had that safety bubble when we were in hospital, really well looked after, and we felt coming home was a massive step for us. So I do share Heidi a lot. I hope she doesn't mind. And it's really to share the lived experience and to try and talk about things and to raise that awareness and hopefully help families who might follow us on their own journey. So in the beginning, this was nearly 8 years ago, but it still feels very clear. I can still hear the sounds and smell the smells of the unit. And these are some of the emotions that I certainly felt, Steve felt as dad, and we know that lots of our families feel. So some of them are kind of negative. There's worry, there's fear, feeling lost, isolated, and grief in terms of what could or should have been. I've put judged on there because I felt judged as a parent, even though that definitely wasn't coming from the people who were working in the surroundings. But it's just to give an indication of some of the things that families might be feeling, certainly in those early days and weeks when literally their world has been turned upside down. But at the same time, there's kind of conflicting emotions. So the really positive ones as well. It was about the love, the hope, feeling very thankful. We were being well looked after. We have got these medical interventions. We're hearing Sudin earlier about the research that's happening to help more and more babies. That all made a big difference to us, knowing that these things were happening and that Heidi was getting the best care possible. And it really was the healthcare teams who had the biggest impact and normalised a medical situation for us. So I guess for all of you working in neonatal care, this is your day to day. But for us, I hadn't been in hospital. I naively thought that once we'd got to full term, that everything would be okay. We didn't know that this world existed, and then we kind of found ourselves in it. So again, it was the nice conversations, the people who congratulated us on having a beautiful baby, and all those seemingly small things, while there was so much medical things going on, that really made a difference as well. And I think at this time, so many of us, our biggest concern is about the future. And we'd heard it earlier that we just wanted to know, first of all, was Heidi going to survive? Was there going to be ongoing issues? Would she walk? Would she go to school? Would she have boyfriends? Would she get married? And you kind of rush and get carried away with yourself, which is really easy to do. And we now try and help parents just focus on the here and now without jumping too far ahead. And I think many of us will agree that the wait and see is absolutely the hardest thing sometimes about a HIE diagnosis. So communication is hugely important, and I've put this slide in because, again, as we talk to families, I think we realise more and more that what's said might not necessarily be what's heard. And again, this comes back to we're not being critical. We know that there's a lot of information to share with families. There's a lot of medical terminology that families might not be familiar with, and it's managing and helping those parents through that process. I remember I think the first example of this for me was when Heidi was being prepared for transfer. So she was kind of an hour old, and the consultant said that she was going to be cooled. And I just couldn't understand what the word cooled meant. And I'd asked the question and they'd said, oh, cooling. And at that point, it didn't match. Why would you cool a baby? I just didn't understand. And also, I didn't want to ask because there was so much going on and I just kind of went with it. But again, it was very clear in the consultant's mind what cooling therapy was. But for me, as a new mum and not knowing what was going on, it just didn't make any sense. I'm also not really sure when we got told the HIE diagnosis, and we have heard from families who tell us that it's only first seen at a discharge letter, for example. And I think we understand that it will have been talked about much earlier than that. But because it's not known, people don't really know about HIE unless it happens to them. I think because it's not familiar, it doesn't sink in. It doesn't really mean anything. So parents are saying that they don't hear it. I know we got given a leaflet about HIE, and I physically held on to that for something, but I didn't find that helpful at the time, because it talked about the outcomes of HIE could be mild hearing loss, but also sadly some babies didn't survive their HIE event, and I didn't know where we sat on that scale, and I think I was too scared to ask the question as well. There was also an example, and again, I know from speaking to other families that others can relate, where the term hospice care was mentioned. This was while we were getting ready for coming home, because of the complex needs and Heidi's medical needs. They thought that we would be appropriate family to be referred to a hospice. Now, again, the intention was really good. I now know that hospices are wonderful places, but at the time I associated hospice care with end of life care, and I thought that meant they all thought Heidi was going to die, but I didn't dare ask that question because clearly I was terrified. And again, it's just thinking of how things might come across to parents or what their understanding might be, and making sure that there's a little bit more clarity around that. So I think it's about checking for understanding. There are different ways of communicating, and each family will want things differently. Some families want all of the facts, all of the data, all of the possible outcomes, and other families aren't ready to hear that, and they might just want to sit in the moment and not think far ahead at all. And there's no rights or wrongs. It's you will know the family's best, and kind of, I guess, respecting what their wishes are in that sense. So one of the things that we do at PEEPS is we really try and make sure that we represent the parent voice. This is through feedback. We have a parent panel. So we bring together families who've got very different experiences of HIE. So it could be different causes or the different outcomes, different backgrounds. And I think you can't underestimate, none of us would underestimate the impact that HIE can have on a family. And as we talk through kind of with a focus group to say, well, what are the really good experiences that people have had, or what are the experiences where things could have been better? These were the key themes that came up throughout that. So there was communication, there was information, and there was support. And I think what has become clear is that things can be very different depending on where people are in the country. And I think that's a challenge in so many situations. But these are the key things that we kind of ask to focus on, because we know that these are what really matters to parents in difficult times. So a few things around the importance of support. It's understanding what's available. And I think an explanation of who does what. I find it really confusing understanding job titles, and we're a little way into our journey now. But at the very beginning, I didn't know who was doing what role. Someone had mentioned speech and language, for example, but I was thinking, well, Heidi's a baby, she won't be talking. Why are we even thinking about that? I now know that that's around kind of feeding or swallowing. Another thing that can cause concern is if social workers are mentioned, for example, as an intervention. Again, we know further down the line that this can be really positive in terms of making sure that support's in place, whether people are entitled to care packages to help look after the children. But for some families, especially in those early days, mentioning a social worker makes them fear and think that they're doing something wrong, or someone's going to be observing them, that they're not doing what they should be doing as a parent. And it's just trying to minimize any concern or upset where possible. And we always say you don't know what you don't know. So we were a couple of years into our journey when we were told that we could ask for a portage worker. I didn't know what portage was, and we didn't know to ask for it. We didn't know it existed. And again, it's just making sure that families know everything that is available. Babies will need different things, clearly depending on their circumstances, but it's making sure that things are explained in a timely manner for families. I think in terms of early interventions, we know how many things are available now, which is brilliant. Parents want to do the best for their child, obviously, as you know, everyone involved in their care does. And I think they also want to know what the future looks like, and they're those big questions that we don't necessarily have the answer to. But I think knowing who can help and being able to access that support can alleviate some of that guilt and worry. So many of us as parents think, are we doing enough for our child? Should we be accessing therapy? Are we doing enough therapy? Are we doing too much therapy? And again, knowing what's out there and what support we can tap into is really beneficial. And I think understanding what's important for that family at that time and understanding that this can change. So an example, we've been asked to be involved in a HIE feeding project, which has been brilliant, and thinking about feeding journeys for babies who've had HIE events. So for Heidi, and I'm sure for the families like Heidi, she was cooled for 3 days, so we weren't able to breastfeed. Oops, sorry. Very loud noise in the background, do apologise. 1 second. Sorry about that, the radiator just suddenly decided to make a very loud noise. So yeah, the feeding. So early days, I couldn't breastfeed because Heidi was being cooled. She didn't have a safe suck or swallow. So even when she came off being cooled, we weren't able to breastfeed. I tried to express, I found that really challenging, and I put pressure on myself to do that. And then she had a NG tube. We then had talks about gastrostomy, and I felt that that was like hope of her feeding orally was being taken away from us. But now 6 years on since she's had that gastrostomy, I see the tube as being a wonderful intervention. It means that she is fully fed, she's getting all the nutrition that she needs, and she's thriving. So my kind of hopes and dreams, I guess, changed as time went on. And it's understanding that that is going to be the case for the families. And that might be around mobility, it might be around speech. There's the whole range of things. It's asking what's important to that family at that time. I think in terms of managing expectations, talking about what support's available, the frequency that might be able to be accessed, the timeframes, what options do families have? So rather than people being told, giving them the choice. And yeah, families talk. There are networks of us out there, so we ask questions and ask people what's going on in your area and what do we need to be asking for. So again, it's managing those expectations from an early point of view. Trying to ensure that there are smooth transitions. I think this is a huge challenge. The transferring from NICU, whether that's via a hospice or to a children's unit and then to home, is a huge step for families. At each kind of juncture, you've got to learn new things. So not only have you learned about your baby in NICU and about doing the cares and being involved in things, when we moved to children's unit, we were kind of more on our own, and that was really scary. And then coming home, again, that's a different change. We didn't have a buzzer to press. We couldn't call someone if we needed to. And that takes time to adjust to that. And again, it's understanding what support is there for the families at each stage of that and making sure that they feel held and supported. And in terms of the community, raising awareness for us, HIE hasn't been that well known in the community settings. We've got great paediatricians who clearly work closely with families, but health visitors, for example, haven't necessarily been aware of it. And we kind of say amongst families, there's a lot of a HI what, and really kind of people are unsure. And it can be difficult for families to have to explain that when we're looking at these people for extra support. So this is kind of the wish list that we put together with our families. And again, this hopefully doesn't come across as being critical. It's just what's come up. Different families have had different experiences. Some have had brilliant ones that they've shared, and there are other things that people said, actually, that would have been helpful for me or might be helpful for other families. So a big one is remember we're parents. For healthcare professionals, like I said before, this is your world and you're very comfortable in it, and we look to you to be the experts. But talk to us about our baby, involve us in the care, and especially before any procedures. So give introductions and explain things clearly again. Please read our notes so we don't have to go through our birth story again. This is a really big one. A lot of families who've had HIE events, it's been a traumatic time, and just taking a few moments to have a glance through the history can save upset, especially early on when things can still feel very raw. Give us the option of having information written down so we can read it after in our own time. Again, there's so much going on. It can be really difficult to digest it. I appreciate that was even harder during COVID when it might have been one parent there at a time. So have those options, ask what families need, what do they want, do they understand it, and have it as a written or alternative formats as well. And ask how much information we want or we need, and is it the right time? This will be different for families at different times again. And naming the diagnosis in a language that we understand. We all are guilty of turning to Dr. Google, but it's important to have a name, and we can then, that will help us access to the right support as well. Explain test results, remembering that they are about our baby. Sometimes results can feel rather cold, or they can feel very serious, or we focus on one thing. And again, seeing things written down can sometimes be really hard for parents to read. So again, explain the test results, but also focus on the baby and how they're presenting. Be realistic whilst allowing us to hold on to hope. So we talked about, we all want to know what the future looks like, and I don't think anybody wants or would give false promises, but it's knowing where we are, what the situation is, but allowing that hope as well. Share with us what interventions might be beneficial and how we access them. And this is from in the neonatal unit, where the support comes to you. But then what happens as we go out in the community? Will they contact us? Do we need to be doing anything? And making sure that there's a clear pathway for the parents. Signpost us to support so we can contact them if or when we're ready. And it's okay not to have all the answers. We understand that healthcare professionals are too, and sometimes being really open and honest can be helpful in relationships. So just very quickly, in terms of what we do, at PEEPS, we have free parent packs. So these have been put together with our parents, so we know that there's nothing scary in there. We don't talk about diagnosis, we don't talk about the future, we don't have pictures in there. It is just gentle information to reassure people that they're not on their own and where to go for help if or when they do want it. We've got information translated as well. So if you are supporting a family and a translation isn't available, please let us know. We can get that sorted really quickly. And we also signpost to other charities and organisations. We're not precious about where families get the support from, as long as they get what they need. So if a family comes to us and we feel we're not best placed because of their circumstances, we will always make sure that they are kind of fully supported and handed over to a more suitable organisation. We offer peer support, so our volunteers have got lived experience. We arrange and fund counselling and trauma therapy, and we run group sessions. And we also support from a financial aspect too, because we know the impact that hospital stays can have. We know that equipment's really expensive for children who do have additional needs. And we also have Sully's Fund, which is for our bereaved families. And we're trying hard as well to raise awareness and to promote education around HIE. So we've got our awareness day on the 4th of April, again, just to get it talked about outside of this setting for the people who might not otherwise be aware. So I guess our big ask from today, if we take one thing away, is to choose to give choices. So at every opportunity, giving the parents the choice. What do they want to hear? What do they need to know? How do they want to access information? And yeah, just giving options can only be a positive thing. And these are our contact details, so please do get in touch at any time if you have any questions, or if you would like packs for your unit, or if we can do anything at all. And I always finish with a picture of Heidi. So this is Heidi this week, going into school as happy as anything. So we do have a long list of extras, and I wish we'd have had a snapshot at the start when I wanted to know what our future looked like, because I'd realised that we are okay. So our okay isn't what we thought it was going to be, but she is well, she is loved, and yeah, we just want to help other people on their journey too. Thank you very much.
Thank you so much. And I've never seen so many hearts floating up and lots of applause coming through. So thank you very much for that, Sarah. That was absolutely fantastic. And really important to hear about some of the work that you're doing. I imagine that you've got some regions of the country where that your support is much more well known than in others. Is that right?
Yeah, so we're reaching more and more networks now, which is brilliant. We're not in all units yet, which is one of our main aims, because we know from families that it is making a difference. And we've had families contact us while the baby's being cooled. For some families, that's too soon. It might be when they go home, or a first birthday, or further down the lines. There's no rights or wrongs, but we've had feedback to say it's made a difference. And yeah, we just want to reach as many units and as many families as we can.
Thank you, and so valuable to hear your story and Heidi's story, and a lovely picture of her at the end there, which was really nice. Can I ask whether there are any questions from the audience? That's tremendous.
I am sorry about the random background noises from the radio.
Sorry, we couldn't hear it very much actually, so I think it was probably more of a problem for you than it was for us.
It was very loud. I've no idea what never happened before.
Fantastic. Thank you so much, Sarah. I really appreciated it, and I think it's all really important that we bring our parents front and center of all of these conversations. So thank you so much for everything that you're doing to try and help us to move that forwards, and I think it'll be great for everyone to be working with your charitable organisation more to help our families. So thank you so much. That's fantastic.
Thank you very much. Love to see you all. Thank you.
Thank you. Okay, so to follow on from that, and I appreciate people have been going for quite some time, we're going to have a very short break after the next session, just to give people 10 minutes. But I think this talk is very timely to include before we have our break. So I'm welcoming Ellie Atkins, who is the lead psychologist for the London Neonatal ODN. She's a chartered consultant clinical psychologist with very extensive training experience, and she's been working for more than 25 years now with children, young people and families. And she's going to be talking to us today about a trauma-informed approach to giving information. Thank you very much, Ellie.
Thanks, Hilary, and thank you for having me. It's really lovely to be here. And you're right, to follow Sarah feels particularly appropriate, because I think we need to start where families are. And I hope what I am going to say will link very nicely. So thank you for your patience not going for your break until after I've spoken. So I'm just going to share my slides. You'll find as I talk that I do talk quite fast, and luckily this is being recorded, so you can always play it back later and catch up. I've got lots I want to say. I'm going to try and squash that all into 25 minutes. So I think when we talk about talking with families, one of the things that happens is that it's something we all assume that we can do. And to some extent, that's true. And I want to give you a bit of an analogy for this. I've never in my life sewn up a wound, given anyone stitches, but I'm pretty sure that I could do it without any instruction if I really had to in an emergency situation. And I'm pretty sure that if you gave me a little bit of instruction that I could do it okay. Because, you know, I figure I'm an intelligent enough person. I have enough skills in this area. I like to sew. I could probably stitch somebody up if I really had to. But if you didn't teach me anything else about wound care, about the kinds of things I might need to look out for, about the kinds of resources I need to use, chances are that something might go wrong or that I might not get it right. And I think talking to families is so similar to this, that we've all got the skills to talk to families, to communicate with them. But I think there's lots more we need to think about around that to make sure that we're doing a really good job. And particularly when the stakes are really high, and they are so often high in the work that we're doing. So I'm going to talk today about developing psychologically informed environments. Sometimes we talk about trauma-informed environments. It's certainly something in the NHS that's gathered real momentum. I think psychologically informed environments is that, but more. I think if we only think trauma-informed, we just focus on trauma. And I'd like to think about the whole environment, not just people who are traumatized within that. So I'm going to explain a little bit about what I mean. I'm going to talk about what that is to do with talking with parents, and then how we might do that a little bit. And when we're talking about the environment, oh, sorry, I was just muted. When we're talking about the environment, we're talking about everything that happens on the unit, the baby, the family, the staff, all of those kind of sit within the environment, and any change in those is going to make a change to the whole environment. And we have to remember, and there's lots of evidence for this, that neonatal units are by their very nature traumatizing environments, not just to the baby, but also to the family and also to the staff. And therefore, any intervention that we offer needs to be offering support, at these three levels. We need to be offering reparative support for those families who've come possibly from a very difficult pre-pregnancy or pregnancy journey, a difficult birth. We need to be thinking that an admission to a NICU is already traumatizing, so how can we repair and support around that? We need to be working to reduce any additional trauma that might come as a result of what happens on the unit, and then preventing further distress. And Sarah gave us such lovely examples of that already in her talk. But the thing about talking, if I just came and told you how to talk to families, I think that would only be a very tiny part of the puzzle. And you can't talk about delivering information to parents in isolation. You have to talk about everything that's going on in the system. And the NICU is a really good example of an ecosystem. When we talk with families, we talk about this idea that you're in this bubble when you're a NICU, and there's this world going on outside, but you're not really a part of that. And sometimes parents say, you know, when I go out to get my lunch and there are people just going to work or going shopping, and my life is focused on this bubble of the NICU, we can see that it really is an ecosystem, and everything that happens influences what else happens. And we know that because of some of the reports that have come out about bits of the environment affect other areas of the environment. I'm going to talk about that in a minute. But like I said at the beginning, I've got now 20 minutes left to talk about a massive, if we're talking about that whole ecosystem and how we impact on that, that's huge. So I'll do my best to do justice to that and just talk about a tiny bit of it. But there's many more conversations we need to have about this. And I've brought this quote to share with you. It's just one of many, but I think probably Sarah has done a really good job of giving colour to the experience of families. Families see us at one of the worst times in their life sometimes, and simultaneously the best time in their life because they've just had a baby. And that's a really tricky place to be for a family. And as Sarah noted, and it's pointed out in this quote, sometimes professionals don't know how to respond to families at that level of emotional arousal. I also think this quote is quite important, and it links to what I was saying at the beginning. And it also links to what Sarah was saying about this coming from a good place. Everybody who I have ever worked in PICU and NICU and in child death have a real passion and connection to the work, feel really strongly about doing a good job. And yet we're not always doing that good job, not the good job that we'd like to. And we know we're not because of all of these reports that we've seen. And I've just picked out the key things that I think relate to what we're talking about today. That we're missing kindness, our communication isn't that good, and compassion is sometimes missing, the lack of psychological safety. These are all the things in the environment that impact directly on our ability to support parents. And this is what Kirkup said recently. I think what he was trying to highlight was that we could produce more and more reports on these isolated or perceived isolated cases of things going wrong in trusts, but actually it's much bigger than that. And I would argue that the bigger than that is that we have to start addressing the environment. So then the challenge for us is, how do we do that truly, genuinely family-centred care, the real kind of compassion that Kirkup and Ockenden were talking about, in a system that's not always designed around the needs of infant and families. It's set up around the medical care, the equipment we have available, the budgets we have, when the staff are available, how the staff want to work. And we're busy, we're understaffed, we're juggling huge workloads, with real challenges. How do we do that? And I think we might recognise, all of us in this virtual room might recognise the need to change, and have probably read some of those reports and know well that things aren't working. But that isn't always that difficult. And I think working in the NHS particularly, it always feels like we're part of this huge megalith organisation that it's difficult to influence or impact. So I'm going to talk about psychologically informed environments and where I think we could make an impact, that we actually could kind of go ahead and make a difference. And when we're talking about psychologically informed environments, we're talking about everything around the environment and the way in which it responds to the psychological needs of the people in it. And I don't just mean the babies here, and I don't just mean the families, I mean everybody who's a part of the environment. And it isn't a whole new way of working. We don't need to scrap what we're doing and start again, but it is a kind of, it gives us a framework to think of, how can we make this better? And there are in the full pie model, there are a number of key elements, and these are they, like slices of pie. And on this infographic, you can just see them, the different areas. And I'm going to talk today only about relationships, because that links to what I was asked to talk about, which is how we talk with families. So firstly, we talk with families by thinking in a systems way and thinking about what's the environment and what's going on around the family. And we know that it will be challenging to do that. And I want to give you a model to think about where our families come from and what's going on for them when we might come to them needing to have a conversation about HIE or anything else that we might need to talk about. And this is a model that suggests that we have three concurrent systems running inside us: the threat system, the drive system that's about motivation, and the soothing system. And a parent might have some of these things going on in their systems at the time. And I've put the soothing in black because I think that those thoughts aren't soothing in themselves. They're the ones that get in the way of being able to soothe, whereas these are the ones that might promote the threat system and promote the drive system. And then we can add to that, can't we? Why are they telling me to take a break? Do they think I can't cope? Perhaps I can't cope, but actually I would really like a shower. I need some time to process and make sense of all of this. Sarah talked about that. They need to kind of think about what you're being told. I really want to work on this bonding, you know, maybe I should be here more. What could I do? Shall I read all these leaflets I've been given? Oh, but maybe I can't bond, and maybe I, you know, what if I read this leaflet and it says my baby might die? And how do I kind of make sense of that? And so you can see it becomes cumulative, and you can get stuck, particularly around your threat system. And what we think happens to these systems sometimes is that one system gets really huge, and to the detriment of the other ones. And in particular on neonatal units, we can imagine that parents' threat system is big. We know this is happening, and we know, for example, that families are particularly at risk of distress if they have a perception that their baby might die, whether or not that's actually a fact, whether or not that's what we think. And as Sarah so eloquently pointed out, sometimes the information we give can be quite unhelpful or misleading into develop, like the hospice comment that Sarah made, making us think that there's a bigger threat or looking at the wrong things as threatening. But alongside this, of course, there's all of us. So we might be thinking, gosh, that baby is really sick. I didn't get paid properly last month because they messed up my hours again. I've never looked after a baby with this condition before. And again, there are things that get in the way of the soothing system. We're short staffed. I'll have to work over my break. How am I going to get to ward round? And a lot of the reasons why we came into these jobs in the first place: I want to be good at this. This is good experience for me. I'm learning lots. I'm really motivated. But then you might think the same things. Why are they telling me to take a break? Maybe I can't cope. You know, what's going on here? But I do need something to eat. How do I look after myself? And you can see how the same thing happens. I love this job. I love being able to make a difference to families. But how can I make a difference to this family because they're so distressed? And we could end up as staff in the same position with our threat systems big. And in the context of everything that's going on politically and globally at the moment, we can imagine that threat systems are bigger anyway. So then what do we do about that? Well, we have some helpful kind of research evidence that supports the ideas that we might progress with. And this comes from Hobful, who developed a model called psychological first aid. It's different from the mental health first aid model, which looks at quite different things. But psychological first aid is an evidence-based approach to support people in traumatic and difficult situations. And it's been used in situations like major incidents, earthquakes and tsunamis and bombings, and I think it's very appropriate to be using on the neonatal unit. And you can see there the 5 tenets of this, and I think they're appropriate for us as much as they're appropriate for our families. So then if we move on to think particularly about difficult conversations, I think the first thing we need to say is there's no quick win. There's no, if you just do this, I'd love to be able to give you that. If you just do this, you can have those amazing conversations with families. You can really target it right. It depends on everything that's gone before. What's the relationship the family already has with the unit? What do they think about what's happening? How did they come to you? How are they experiencing so far? What interactions have they had with staff? And I also think it's important to think about the reasons we came into these jobs in the first place. And this is those content-centric circles again. I think lots of people who work in intensive cares across NICU, PICU and adult, there's something about liking the drama or the pace of the work. We like to be in the thick of it where we can really make a difference. And therefore, the bits that we bring can also come into these conversations too. That's again what's gone before. We might be drawn into these conversations because they're part of, I can really make a difference here, or I can do something, I've got good skills, and kind of fired up by that. And we need to be thinking about who's the right person to have the conversation in the room, who has the best relationship with them, who has the right skills to be able to have this conversation, and how might we do that? And it's also about how many reserves you have. How much compassion have you got available? And I think this was already mentioned, and it was in that brilliant video that NHS Scotland have done about thinking about it and planning it beforehand. So often conversations happen on the hoof because that's how a lot of our work happens in critical care. But where you can think about what you're going to say and what's important, what you know about their family already, you're going to have a better conversation. And in terms of giving you a framework for thinking about this, I want you to look at this model, and I want you to think about the ways in which we know the brain functions and is structured. And if we're going to have a difficult conversation, we need to start at the bottom, because the cortex, particularly the frontal cortex that does all our planning, organising, reasoning, is not online when we're in high threat mode, because that's not the way our brain has developed. Our brain has developed to keep us safe, to respond to threat situations by shutting down the functions that we don't need and just using the ones that we do. So a lot of our families are in fight or flight. They're particularly going to be in fight or flight if their baby's very sick, if they think something terrible might happen to their baby, if they've just had a very difficult labour and birth experience, maybe they've just transferred. They're going to be in that quite shut down position, and therefore we've got to start at the bottom. And I'm just going to talk through for a few minutes about how we might do that. So we start with regulate, and that's about the quality of the conversation. It's about naming and acknowledging the feelings that you see. It sounds like you're really angry, or I can see that you're really upset. Just naming that allows the parents to feel safe and feel calm. You're kind of really grounding them where you are. And then you can move up to the relating. Don't forget to tell them your name. I know we get told this all the time in the NHS, and it really is quite basic, but often what happens is you meet somebody, you tell them your name, you see them the next day and have a conversation with them, maybe about their HIE, their baby's HIE, and they're not necessarily going to remember. On NICU and PICU, it's a bit like a circus quite often, isn't it? That professional after professional turns up at the cot side in order to talk or to examine or something, and the number of people you see means you won't always remember them if you're a parent. And you need to build a relationship, remembering that they might not be in their kind of best performance in able to build a relationship, and you have to do the work on that. And you're doing this, you're trying to help them feel safe and calm and connect with them. And so you're responding to those needs that they have in that moment. And then only then can you get to the point where you can help them to make the decisions that you might need to make with them. I think for parents, so often it feels like you're in this maze that you don't know, you don't recognize, and you have no idea which is the path you're supposed to take. And only when you've done those other stages of regulating and relating can you help parents to reason. And then you need to keep it really straightforward. Sarah's already touched on this, so I'm not going to spend too long on it, but we're trying to get to a point where parents feel at least we're going down that road with them. And that's where we're doing these, making use of the strength and skills that parents bring and maintaining hope that, again, Sarah talked about. So here's a Cliff Notes version of what you might say. You might say why you're meeting. Then you might tell them what it is that you're going to tell them. And then you might summarize it. And if you've ever done any kind of presentation training, you'll recognize this, because this is the tell them what you're going to tell them, and then tell them what you've told them. And this is the same. Remember, in threat brain, we're not processing very well. So I've just broken it down a little bit so you can see. You first can cue them into the conversation. Hello, this is me. Remember, we met yesterday. And you need to take where they are and start from there. You can't start from where you want to be. You need to go from where they are. And then you use short sentences, remembering they're in threat brain. Use simple language, but do give them the diagnosis. And then build the narrative over time. This is what we know. This is where we are. This is what the next steps are. Quite often, we start with the next steps before we've told them where we are. Do that in kind of sequential time order in order to help the family follow through where you're going. Often I see this a lot in conversations that parents are asked to repeat back what they've been told in order to check that they've understood it. It's clearly something that's taught in communication training, but you might want to repeat what you've said in a shorter way. When I'm in conversations of this sort with a family and usually a doctor, quite often what I do is say, so is what you've just said this? And I think sometimes the doctors look at me and think that I'm a bit crazy, that I maybe haven't quite understood what's happened. What I'm really trying to do is reflect back in simple language at what's been said in order to help the family be able to take it in. And then give family thinking time. I think sometimes we do this well and other times we don't do it at all. What do you think? Well, I don't know about you, but I can't make a decision off the hoof about anything, let alone something that might be to do with how well or ill my child is. So allow the family to have some time to think, and remembering that when we're calmer, our brain functions better. And remember that the quality of this will come from the quality of the relationship prior to this conversation. So everything that's gone before leads up to your ability to be able to do that. And that isn't just on you as individuals, that's on the whole unit. Because I think, as I've been alluding to all the way through this talk, there's so much more that we could talk about with this. And moving towards being psychologically informed is a systems approach. We need to be thinking about what it's like for a family when they first present to the hospital, potentially in preterm labour, when we do transfers between units, when they're on maternity, and that neonatal interface. So when the neonatologists say, come down to maternity before the baby's even born, those things we really need to think about. How are they psychologically informed? How are we setting up the relationship we're going to have with that family? Then we need to think about admission. And by that, I don't just mean when we rush the baby in and kind of work on them, but what's it like for that family coming down, walking through those doors? What do they see? Who talks to them? What kind of is going on for them? Remembering that they're in threat brain. So you might have a lovely induction process where the first time a family comes in, this is what happened. We give them this information, we talk to them. The family may or may not be able to take all of that in. So think about how you're doing that. All of the communication that happens, what facilities are available for them, and how do families find out about that? What opportunities are there, like, for example, family integrated care groups? What routine cares happen and how do they happen, and how are transfers managed? And then onward, I think this is a whole other area that the National Leads for Psychology haven't really had capacity to think about yet, because we're focusing so much on making sure there's good psychological care for inpatients, but psychological follow-up care is not there for very many families at the moment. And I'd like to see a psychological thinking being built into discharge planning, into all outreach work, into outpatient follow-up. I'd like there to be areas on Badger that make sure that we're thinking about the mental health of families and linking up with the community. There's a lot more to discuss in that. But if we just kind of go back to thinking about what you're doing on the units, I think one of the things we really need to be working towards is really fully staffed, functioning MDTs. And I mean MDT in the widest sense of the word, because until we've got fully staffed teams that include all the skill mix that you need to develop family integrated care, to develop good psychological care around a family and around a staff, then we're missing bits and we're never going to be able to do everything that we want to do. Now, this graphic that I know you won't be able to see terribly clearly on your screens is in the psychology staffing standards for neonatal care, which you can find. The link is there, but it's on the BAPM. If you just put BAPM and then psychologist, you'll find it. But it's only when we're attending to all of these layers, from a voice to babies right down to the ways in which staff have felt psychologically safe, that's when we're going to be able to offer better care. So I'm just going to end with this quote. I think we've worked through an NHS era where it was about metrics, about the data returns we could give. I think we're still in this era. But I think, you know, as Kirkup so eloquently put, if we don't start thinking about humanity and compassion and about the ways in which we set up our systems to support everybody who's in the system, then I think that's a failure on our part. And I think all of us have a role to play in inspiring that humanity.
Thank you so much, Ellie. That was a fantastic whirlwind tour through your entire life's work, really, I think, and I can see that there's so much more that that you could have given if we'd given you more time. So thank you so much for the jewels that you've given us there, and lots more food for thought and for people to come back to. Does anyone have a specific question to ask Ellie before I move us on? I really felt it was very good food for thought, Ellie, and I really hope that we get more psychological support and more humanity in our neonatal units. I think we would all agree with that. So thank you so much, Ellie. So I'd like to welcome Sam Oddy, who is the National Clinical Lead for the National Neonatal Audit Project. Sam is a neonatologist in Bradford, in West Yorkshire, and he has been leading NNAP now for many years, actually, and doing an excellent job of that, and also provides neonatal clinical input into the National Maternity and Perinatal Audit. And he is the lead for research in his trust and has also been a co-applicant on a number of clinical trials. When he's not working, and he's given us some interesting information about himself, he likes gardening and building things and caring for a very small fiberglass boat, which it sounds like he isn't able to get to that often as it's in the West Highlands. So thank you very much, Sam, for agreeing to talk to us today about the NNAP data about that we have for neurology and where we go to next. Thank you.
Well, thank you, Larry. I'm hoping that you can see some slides and that they're reasonably large on your screen.
Yes, we can.
Fantastic. Well, thank you very much, Larry, and to BAPM for asking us to talk. I'm talking on behalf of the NNAP project team. I'm slightly embarrassed to be giving what's perhaps a relatively pedestrian and I'm sure a significantly less eloquent presentation than my predecessors. But I wanted to talk to you about the as Larry says, the IVH and PVL data that we've published in the report. Now, my experience is that people tend to at least double, if not triple, device during webinars. So I imagine that you may want to look at your NNAP data on NNAP online, and I won't be in any way offended if you do that at the same time. But what I'm hoping to do is to give you some idea what the 2021 data report shows, and to focus on IVH 3 and 4 and cystic PVL, and to mention PHVD, and then to try to think about, does it matter and what we might do about where we're at and where we're going in the future. And I'm hoping to get off in sufficient time for you to ask some questions, because that's always good fun. So the first thing I wanted to show you was, and apologies for the not very elegant slides stretched sideways to fill the screen. So this is a so-called spine plot where the vertical line in the middle of the plot for Bradford shows the national average, and the diamonds, the black diamonds, are the regional average, and in our trust are represented by the sort of purple stretched dots, purple, perhaps they're pink, who knows? And they're summarizing a number of processes and outcomes for this particular trust, my own, all on a single page. Now you'll notice that brain injury, if you can read it, the brain injury doesn't feature on this slide, and that's not an accident. For reasons that I guess you may be aware of, but will become clear. But I think I want to point to some things that NNEP is able to very confidently describe that I think really does matter. So here is the gestation group perhaps most relevant to this outcome. Babies are less than 28 weeks, and this is mortality on the vertical axis. The top panel here shows crude mortality, overall about 15%. But you can see by neonatal network, it varies by a factor of 2. So in this case, so it's more than twice what it is in one network compared to another. One shouldn't get too obsessed with the ranking in these Caterpillar plots, because dots next to each other tend to have very strongly overlapping confidence intervals. But I don't think it's difficult to be persuaded that just from that top left panel that there's a difference in mortality. Nonetheless, we found that people want to explain their results by the characteristics of their background population. And so the bottom left panel addresses this issue by doing a form of case mix adjustment. It produces on the vertical axis something called treatment effect. So the difference in mortality that is associated with being looked after in a particular neonatal network. And you can see that roughly the order of neonatal networks is almost exactly the same, and that there's still a striking difference between in mortality differences. This is 3-year epochs. So I hope that that's a fairly uncontentious finding. I think it's important, and it will slowly change because of the 3-year epochs that are represented. So here's another outcome that we think is striking, same sort of format, top left panel, crude rates, again by network of bronchopulmonary dysplasia, an outcome which we, as you know, measure by use of breathing support or supplemental oxygen at 36 weeks postmenstrual age. And you can see, and this is a long-standing finding, that there's a marked difference between neonatal networks of around 10% in the crude rates, and the same, you see the same sort of difference, a little bit, there's a little bit of contraction here, and the treatment effect. So you can show the same difference between neonatal networks, even if you take into account the baseline characteristics of the babies. So with that said, let's think about preterm brain injury. So I think this is, I'm not in favor of people who say that there's only 5 diseases in neonatology, because they clearly haven't done any neonatology. But we do have dominant patterns of clinical disease, and brain injuries are clearly a major outcome, and was one that we weren't recording in an NAP until the first year of data we reported was the 2021 data. So for IVH, the outcome that we're looking to describe is in an ultrasound or MRI before 28 days of age on both left and right side. Was there a grade 1, grade 2, grade 3, or grade 4 hemorrhage, or indeed no hemorrhage? Now, the definitions here are an adaptation from Papille and Volpe, and we formed these after concluding that neither Papille nor Volpe were adequate for describing what we needed to describe. And so we formed an expert group, which I was slightly uncomfortable to be a member of, and then came out with a consensus document, which we then took out for peer review to people whose names would all be familiar to you, And there was a very strong agreement with the definitions that we proposed, some minor tweaks to the wording. But you can see that, as in particular, there's a clear definition of a grade 2 hemorrhage, and I hope that that's reliably differentiated from a grade 3 hemorrhage, which is more than 50% of the ventricular area in parasagittal view and typically distends the lateral ventricle. So we have some clear definitions which we hope are reasonably straightforward in principle to operationalize. That's been my experience. We are not simply measuring IVH. We also wanted to consider what was felt in the expert group that we should measure post-hemorrhagic ventricular dilatation, PHVD. And here we're looking to measure on ultrasound or MRI at any time. Was there past IVH and enlarged and currently enlarged ventricles with a VI above the 97th centile, more than 4 millimeters above the 97th centile on the Levine chart. And finally, we've developed a case definition for cystic PVL, which is not controversial: multiple small paraventricular cysts, excluding, of course, conatal cysts. So hopefully we think these are, people would agree these are reasonably clear operational surveillance definitions. Whoopsie daisy, so that should have gone there. Shouldn't be in there. Here are the unit level data. So many of you will have seen these plots before. In this particular plot, the NICUs are represented by red or pink dots, and the local neonatal units are represented by blue dots, and the special care units are represented by grey dots. Many of those dots, but by no means all of them, have confidence intervals around them. Those units with confidence intervals around them, those represent units that assured us that they were confident in their IVH data. And you can see that quite a lot of units, about a third, weren't confident in their IVH data, and I think for good reason. So nonetheless, I think if we look at this, it's possible to understand that there might be an NICU with relatively small confidence intervals that reporting quite a low rate of IVH 3-4, and then there's an NICU here, so that's under 5%, reporting a rate of 3-4 IVH of in excess of 20%. So apparently quite a lot of variation. And here is a caterpillar plot, again, same sort of plot, rate of 3-4 IVH by neonatal network. And overall, the rate is about 14% or 15% of babies of less than 32 weeks. However, there is really quite a lot of missing data. So I draw your attention to one particular neonatal network that has a missing data rate of 50% in the green, and I'll explain the other columns in a moment. So I'm going to just ignore that, and I've shrunk the vertical axis in order to draw attention to the data more closely. So in the previous plots, I was showing you the rate, because babies who have IVH, death is a competing outcome. So we've presented these as IVH. In the summary plots show rates of IVH or death. Now this is the what's that? Is that a rust red? That's the same data presented in a different way, and it's broadly in the same. It's the same order as the caterpillar plot. So you can see that there's a variation in the rates of IVH 3-4, but the missing data is in green is really very substantial, as you saw in the previous graph, and the rates of IVH are vary substantially within this. So this is just IVH in blue, and you can see that that forms part of this composite outcome of IVH or death. So our conclusion is that the missing data very much undermines the utility in this first year of measurement, and so I'm going to show you the cystic PVL data. So cystic PVL, about 10% of all babies under 32 weeks, that's cystic PVL or death. And here we see some apparent variation, but again, there's a great deal of missing data, and I haven't got a figure to show you that. We chose not to present the data for PHVD, partly because we note the striking incompleteness of the IVH cystic PVL data, and because we know that when we introduce a new measure, it takes quite some time to build data completeness and, in effect, accuracy to a level that's helpful, and we've seen that with a variety of other measures. And the other complication of the PHVD is that in order to know whether a given scan exceeds the 4 millimeters above the 95th centile on the 97th percentile on the Levine chart, you actually need to use a Levine chart. And our soundings suggest that people haven't been cleaning their data to this extent. So does any of this really matter? You might argue, well, IVH doesn't really matter, and it's not really worth all the effort of trying to measure it. Well, I don't agree with that, strangely enough. So we know, of course, that from this well-cited paper, a reference at the bottom of the slide, that brain outcome is worse following postnatal transfer, upward transfer. And this is the paper that has put such a lot of emphasis, or it's amongst the data which puts such a lot of emphasis on a need to accomplish IUT. You might notice that this data was collected in the past, and that data completeness was worse then. So it may be that relationship is still stronger, or it may be different. So I think in order to monitor the effectiveness of our clinical change, we need to know what the brain outcome for the babies is. There is, of course, a national ambition introduced when Jeremy Hunt was Health Secretary. Remember when he was the worst Health Secretary we'd ever had? So Jeremy Hunt has introduced a national ambition to reduce brain injuries at or soon after the time of birth. So preterm brain injury forms part of that composite outcome. And this IVH data, incomplete though it was in 2021, and certainly prior to that, is being used currently to monitor the national ambition. Of course, IVH is strongly associated with physical, in particular, developmental outcome, and there are probable, but there are probable outcomes, associations with other intellectual outcome. But ultrasound is, as we all generally know, a poor predictor of intellectual and non-physical developmental outcome. I think, as one of our reviewers put it, that everyone, well, I hope that everyone accepts that IVH 3.4, for example, represents a bad outcome, demonstrably a bad thing. And so I hope that you'll be persuaded that it really does matter and is worth trying to measure it. And I hope that we might get to a situation like that shown on the graph here. So this is for a different outcome in NAP. So namely, the proportion of babies who get a bloodstream infection with an obviously pathogenic organism. This babies of less than 32 weeks. And on the top panel, again, you see the rate of bloodstream infection. Confusingly, the colors are slightly different here because we have surgical neonatal intensive care units in green and neonatal intensive care units without surgery in red and LNUs in blue. But then you see the treatment effect, and I'm persuaded personally that there is real variation in it's more limited treatment effect analysis, but that there is real variation in rates of infection. This is a single year's worth of data to suggesting that there really that some of us are better at preventing infection than others, and so I don't think it's too much of a stretch to think that we could improve brain outcomes. But in order to do that, we really need to know if we're if we have a high or a low outcome, whether it's infection or in the case of neurological outcomes I was talking about. So I wanted to say something about future NNAP reporting, because I think that will affect how you see all of this. and also because we want to start to get your comments about this. So from the middle of this year, quarterly, and then potentially in the future monthly, we will start to report NNAP metrics in close to real time, so quarterly and then potentially monthly. We'll be reporting the most recent epoch. And so that means that in June 2023, so a few months' time, we'll report the first quarter. And then later on in 2023, we'll report the second quarter. Then there'll be less and less lag. So there'll be very little lag between the time that things happen and that we report. And the first thing we're going to report is the POP6, the Perinatal Optimization Program 6 interventions that we report. So there's this concept of data for improvement versus data for insurance, for assurance. Insurance would be something else. The outcome that I particularly want you to think about is this composite outcome that we will be reporting of the proportion of babies less than 32 weeks, so very preterm infants, who did not have a serious complication of prematurity. And by a serious complication, I mean late onset infection, NEC, BPD, serious preterm brain injury, and of course mortality. So the reporting for your information will look like this. On the horizontal axis in the main panel on the top left, you see 2016 through to 2022. The rust color, the orangey color, is the amount of missing data, which you can see is very significant even for this metric, which we're very interested in the hospital that's shown. The blue line is the performance of the unit, and the green line is the national average in the middle of the middle 50%. The light grey is the middle 80% of units. So we propose to report, to start with the POP6 outcomes, but then all outcomes in this format, which we hope will be helpful to you in your clinical improvement work. So that's kind of the future of reporting, and it's worth saying that this blue line here will be dotted for the more recent quarters until the annual data assurance process is ongoing. But I want to just describe something about the annual data assurance process as it's currently running and how that will need to change. So at the moment, the data validation, data assurance process is really driven by our so-called quarterly reporting, which this reporting will come alongside with. So the quarterly reporting, quarterly reports that we send out to units, they look a little bit like this. Here's Bradford's report, and the intention of these reports is to show how the NNAP data looks to you, looks to us, that you've submitted through Badger. We do provide some comparisons to the national average, which may or may not be helpful for your QI, but that will change as you've seen. Importantly, there's this Excel sheet alongside that, which comes to you and is available to anybody who's interested within your organizations, which will describe who's got an outcome, who hasn't got an outcome, and whether there's any missing data. So that occurs 4 times a year. The so-called Q4 report for the 2022 data is going to be generated in the next few days, so it'll be coming out to you next week. And then there's a period, as we currently run the audit, of 6 weeks, and this will continue in the new contract. And there'll be 6 weeks for the final assurance, and we will then report the Q4. We'll then report the annual report, and we'll liberate the data as soon as we're able to. The final part of this validation process is a data validation survey. So I showed you earlier for some outcomes that some units tell us that they're confident that their brain injury data or their NEC data or their infection data is all correct. And we send out this validation survey, and we'll keep sending it to people who don't answer until we get an answer. So the quarterly reports look like this. Importantly, they refer you to the measures guide, and the measures guide, should you want to read more about the brain injury definitions, is here. People very often need to go back to individual patients' data, and I wanted to show you what the Badger data entry page looks like. It's in the procedures, and you go to brain scan, and here we have right and left. And if you click on these little question mark boxes, it brings up the definitions that I've already shown you. And the same is true for PHVD and cystic PVL. So this is in the and in one more thing to show you. So the way that we review our data clearly varies between organizations, but I am confident for the way my own clinical team work, that if I simply believe the ultrasound data that people have entered, that scans will be missed and some scans will be misdescribed. So I go through every patient's individual brain outcome, and by reviewing their headline diagnosis in the letter, not very helpful. I skim the summary section of the letter, and I sometimes read the central nervous system section of the letter. I often end up looking at the radiology reports, not usually the images, because I don't really interpret images. And I sometimes will speak to the radiologist if it's unclear whether they, for example, are a 2 or a 3 or a 3 or a 4. So I think for me, in my centre, it's necessary to review each individual baby's material, and I then keep a record on the spreadsheet. Of course, that's kind of closing the door after the horse is bolted. What we really need to do is to build a process that's fit for purpose. So it's something about telling our trainees and other people who enter data how the data should go in at discharge. When somebody signs off a discharge process, they are asked to verify whether it's true or false how many ultrasound scans the baby has. That was intended to drive them to clarifying what those scans had showed. And we are keen to I think it's important to keep promoting the agreed definitions which came from this national consensus group, particularly to radiologists, but also to consultant colleagues, and speaking to the trainees next month. And the frequent reporting will, I hope, build the quality of the data further. So where are we going next? I think Elaire's probably telling me I'm nearly off. I hope that we will continue to improve the data completeness and the data accuracy. And I think this is personally, I think it's a really important outcome that we can describe. The measures guide, the quarterly reports, the assurance survey will, I hope, support you in your cleaning of the data. And in the end, I hope we'll be able to make a useful report, a useful answer to this question: the proportion of babies of very preterm infants who do not suffer a serious complication of prematurity. And that's one of the metrics that we'll report. I'll get off and thank you very much for listening. I don't know if there's any time for any questions.
So thank you so much, Sam. Really, really helpful to hear through. We've gone a little over time, but I think if people are willing, I'm sure there will be a few questions. Firstly, I must apologise, and somebody has given us some very helpful feedback about not picking up on questions. And this is actually because I've been thrown out of the chat quite early on this call for some reason. So I wasn't aware of all these lovely questions coming through. So I think we've got time for 2 questions. So if anyone wants to raise their hands, otherwise Kate, who can still see the chat, will pick up a couple of points that have already been made in the chat. Kate,
I can see the chat.
You can see the chat. Fantastic. If you can, if you're able to do that, that would be great, because I don't know why I've disappeared.
You must have done something very bad. So Joe Wright in Leeds says, will there be additional resource and data support if the month? So you're lucky in Leeds to have a data analyst. So I think if you think you need more support with that, I know that there's a local QI program working in your particular organisation around this area. Then I guess approaching your ODN is the right thing to do. If you think you need more support beyond that. Do you have to input the diagnosis, says Katie Cullen. I hope I've answered that question as I went through, but in effect, if you enter the ultrasound, the worst ultrasound for each outcome, then that's sufficient. If the baby has 340 scans, or perhaps 20 scans, as some units do a lot of scans, then you don't have to put all 20 in, so long as you put the worst scan for each of those outcomes in.
Thank you, Sam. I'm just going to, there's somebody with their hand up and it's going to be the last question, if that's all right, just because I need us to move on. I do apologise. Justin, did you want to come in and ask a question?
Yes. Hi, Sam. Very interesting data. Carrying on the good work as always. I suppose my question is just thinking about it from a tertiary unit perspective, and having looked at our own mortality and brain scans in some detail over the last 28 years or so, just going back, because I've been doing it. It's a pet project I've been doing for quite a long time. What's interesting for me over the last 5 years is we've seen an increase in mortality in this group. And it's not until I go into the individual gestations that I find out why. Because actually at every single gestation, our mortality has decreased. It's just we're seeing a completely changing pattern of preterm babies coming through. So we're seeing a lot more 22, 23, 24, 25 weekers than we used to. And I think that probably reflects referral patterns, because a significant number of our babies are out of our network and even out of London, actually, that come through. And I just wonder how you pull this out of the morass when you're trying to compare things together. I'm just curious of your thoughts.
So I think what you're saying is that the baseline characteristics of the babies are changing over time, and implicitly that they might differ between organisations. And I absolutely take both those points. The most fulsome version of risk adjustment that we've done, so the matching that we've done for BPD, takes into account lots of background variables. So some birth characteristics of the baby. The matching analysis that I showed you for infection rates takes into account the gestation and possibly the birth weight. I'm ashamed to say I've forgotten, but I think it certainly includes gestation and possibly I think birth weight as well. It's more challenging to do meaningful case mix adjustment, which is not quite the right jargon, for a rare outcome if you keep the epoch short, which is probably the right thing to do for quality improvement purposes. I think as a community, what we need to do is to build the accuracy of the way we describe this, so we can do an apples to apples and a reasonable centre to centre comparison, and then to do the adjustment for baseline characteristics that you identify as so important.
Thank you, Sam. I'm going to finish you there because Shailendra's very patiently waiting to give the last talk, and I want to make sure he has enough time. But thank you so much for a fantastic talk as ever, and all of the work that you do for NNAP. I think it's been a fantastic resource for the whole neonatal community. So thank you so much. So moving forwards, our last talk this morning, which will be going on until 1 o'clock. So I hope everyone is able to stay for that. So I'm introducing Shailendra Magdum, who is a consultant neurosurgeon, originally working at Birmingham Children's Hospital, and then has moved to the paediatric division of the Oxford Neurosurgical Department, where he's been since 2009. He is predominantly practicing paediatric neurosurgery and craniofacial neurosurgery, and he's also worked in Africa for the last 5 years doing complex encephalocele repairs, and has a lot of expertise in craniosynostosis, craniofacial and Chiari malformation surgery, as well as midline tumours in children. More recently, the effectiveness of endoscopic ventricular washout locally has triggered his research in this area, and he's going to be talking about this today as part of a talk around current therapies for management of IVH and post-hemorrhagic ventricular dilatation. Thank you very much to Shailendra. We can't hear you, Shailendra. Apologies.
Sorry, I was saying good afternoon, everyone. Thank you for inviting me to your talk, and thanks for the excellent introduction. I have got with me Susan, who's an academic trainee who has helped us to write the recent paper we have. I hope you can see the screen and the slides.
Yes, we can. Thank you.
Okay, thank you. So I'm going to talk about mostly a quick management of postnatal post-hemorrhagic hydrocephalus, and everybody knows about the germinal matrix hemorrhage and how to grade them, but it's about 15% of extremely premature infants, and more than half of these developed the dilatation. And despite of many decades of investigations, Unfortunately, there's no consensus among neonatologists, pediatric neurologists, or pediatric neurosurgeon as to the best management of these cases. And basically, it contributes to the brain injury, which underlines the adverse neurodevelopmental outcome. What is the pathophysiology and neuropathopathology of post-hemorrhagic ventricular dilatation? As you are aware, active development occurs in the human brain from 24 to 40 weeks of gestation. The most important structures are the microglia and the astrocytes. We help in the development of white and gray matter structures. They're involved in formation of the axons, the myelins, the vascularization, the synaptosis, the synapse formation, and the neural circuit formations. However, when these cells get activated by blood products and other deleterious products such as infection, they can cause very different stimulation, and they develop into pro-inflammatory phenotypes and divert the process from roles of forming the normal glia to something which causes more of a tissue damage. The vast majority of the post-progressive ventricular dilatation occurs due to the consequence of this. So that is why it is important to understand that the bleeding around this area is very, very detrimental, and what can be done, because the heme that's released from the hemoglobin is taken up by the microglial cell, and the iron from that facilitates the formation of injurious reactive oxygen species, which affects the oligodendrocytes and the axons as we go along. The consequences of this hemorrhage leads to ependymal disruption, axonal injury, microglial infiltration, and impaired myelination. And you can understand all that thing can lead to a very bad outcome in the child. The deleterious effects are multifocal. In addition to the ischemia, there is mechanical distortion due to the ventricular dilatation. There's inflammation due to the blood and other factors. And ultimately, the blood can release free radicals and iron, which are pathogenic for this brain when it's developing. And that's why an early institution of intervention that involves CSF drainage seems to be important, but there is no consensus about timing. Even the early institution of intervention is still coming to a consensus, but not yet. So that's why it's my interest to see that what is the best thing for the children, because I'm going to talk about the various trials we had in the past and various ways we used to treat them. Again, this is important. Relationship of the ventricular size to the outcome. Very preterm informed to develop severe IVH or periventricular hemorrhagic infarction in grade 2 or 3 are very likely to prone post-hemorrhagic ventricular dilatation. And there is impairment of CSF production absorption, and the ventricles may dilate around 7 to 10 days following the onset of intraventricular hemorrhage. This all depends on how much CSF gets stimulated to produce and dilate the ventricles. It can be slow or rapid progress. In slow progression, stabilization and regression can occur in more than 65% of the cases, but in about 30 to 35% of patients, the progression of ventricular dilatation is rapid, and it can happen within days or 2 weeks. So that's why there is a difference between these two categories of intraventricular hemorrhage and progressive ventricular dilatation. Timing of interventions. Some centers have started intervening early or late. Some of them based on the sequential cranial ultrasound measurements, others based on the clinical symptoms, which was the traditional teaching when I started doing neurosurgery, like waiting for apneas, vomiting, full fontanelle, sunsetting, or splaying of sutures, rapid increase in head circumference. And these are very classical teachings from our neurosurgical days. And that probably needs to change by new education to say that we shouldn't be waiting for that long. In preterm informed, there are two factors that reduce the sensitivity of the standard classical hypothesis of raised ICP, which includes that saying that this is a closed box and things will the pressure in the brain will slowly be readily seen by clinical means. But you have to imagine that there are sutures, there are soft fontanelles, and that won't be that good in measuring how much pressure in the brain this child is going to have to cause a damage. So this should be changed now, and we should probably think of more of ventricular indices and agree on the fact of which measurements we should take. The first factor of, as I said, was the compliance. The compliance is higher in a preterm infant, and the low pressures are sufficient to cause progressive ventricular distension. And that can result into compression of the cortical mantle before the effect on the sutures or head circumference. So the brain can get compressed before you start seeing any signs in the head circumference, fontanelle, or the sutures. And due to the large extracerebral spaces, which is due to the fact that the myelination is not yet happening or not in place, we get a lot of large extracerebral space, and you need a lot of ventricular dilatation before again you see the changes in the fontanelle pressure and to see the rapid increase in the head circumference. So there is, consistent with this notion, a poor correlation between the Evans ratio, the ratio of the bifrontal horn of the bifrontal horn and the diameter of the skull and the head circumference. So it is all now kind of come to a very good conclusion that the cranial ultrasound is a better way to diagnose and follow up the progression of periventricular intraventricular hemorrhage, ventricular dilatation. These have been the neurosurgical interventions in the past, where they have tried various things such as lumbar drainage, ventricular taps, acetazolamide trial, and the more important, probably the game-changing thing was the drift trial, which has given us interesting outcomes to the studies. There have been Elvis early and Elvis lates, and there have been Dutch units and North American units trying to do different things, and we'll come to that. And what are the optimizing? Why are we renewed this interest in optimizing the neurosurgical treatment with infants with post-hemorrhagic ventricular dilatation? It has become the most common etiology of hydrocephalus in Europe and North America, increasing trends in incidence of prevalence of the same, the severe neurological morbidity and lifelong complex neurosurgical care that is required, and data suggesting a potential benefit in standardizing the treatment. And we have to have basic and transitional science providing a scientific rationale for early intervention, which is now getting to that level. So I'm going to hand over to my academic fellow to kind of talk about our paper and assessment for evaluations. But you all are aware about the ventricular indexes, and mostly the ventricular index, which is the Levin and the Starte, is most commonly used to measurement, and it is to be done in the coronal view. We also use the measurement from the thalamic margin to the occipital horn, because the frontal and the occipital horns can have a different configuration and sizes. The VI is the border between the midline forks and the lateral part of the ventricle at the level of foramen Monro. And the absence of any extraaxial space supports the conclusion that the dilatation relates to the CSF accumulation. But if you see a lot of periventricular spaces, then you have to suggest that this could be cerebral atrophy causing ventricular dilatation. The challenges of management. Susan.
So I'm sure this is all very familiar to all of you, but the things that do make managing hydrocephalus in these neonates so difficult is that the typical way we manage hydrocephalus, which is usually through shunting, is very challenging because these neonates have immune immaturity, meaning they're high risk of infection. They have comorbidities of prematurity, such as necrotizing enterocolitis, which means the abdomen is very hostile for inserting the distal end of a shunt. They may also not have sufficient peritoneal absorption of any CSF that we do divert to them. And also there's a high protein load in their ventricles, which means that a shunt is at high risk of blocking in these patients. So in order to try and address this over the decades, there have been certain measures that we can take in approaching the hydrocephalus. And the first thing really to talk about is performing serial lumbar punctures. And a couple of recent studies or reviews have shown that it seems that no matter whether we perform early lumbar punctures, late lumbar punctures, there seems to be no significant effect in delaying the ultimate outcome, which is that these patients do need to go on to have CSF diversion. And every time we do perform a lumbar puncture in these patients, there is of course a risk of infection. So it's something, if possible, to be avoided. The other option that we have is performing a ventricular tap, which applies the same principle of draining off a volume of CSF to relieve the pressure. This also comes with the risk of infection. And of course, every time we perform a ventricular tap, we go through the frontal lobe of the brain, and there's risk of porencephalic cyst formation. This is something that is extremely useful in extremis, but is something that ideally would be minimized. The other options that we have are inserting ventricular access devices, and a diagram of this is shown on the slide on the left. And this involves us having a small piece of tubing which sits within the ventricular system, with a reservoir then sitting underneath the skin, which allows an easy port of access to drain off CSF. Again, every time we access this closed system, there is a risk of introducing infection. In order to try and address the risks of infection, we do have the option of ventricular subgaleal shunting. And this involves us placing a catheter into the ventricular system, which then drains into the subgaleal space, and then that fluid can be reabsorbed within that compartment. This has the advantage of reduced infection risk. However, it has the disadvantages of potentially having uncontrolled drainage. And also, if we do have that collection of CSF sitting under the surface of the scalp, there is a risk of it leaking if it becomes high pressure. Going back to the things that already Mr. Magdum has spoken about in terms of the actual pathophysiology and long-term function in these patients, we know that there are deleterious effects of having a clot burden sitting within the ventricular system. And this really brought about the DRIFT trial. Now, this is a trial that was published in 2007, and it involved washing out the neonatal ventricular system with recombinant tissue plasminogen activator to break down the clot and irrigate the ventricular system. And the principle was a great idea, and we saw that actually long-term outcomes in these infants were good. However, there was a high rate of rebleeding at the time of procedure, potentially unsurprisingly, given that we're using TPA. But the findings from this study, it caused it to be discontinued, but the principles were a useful idea in moving forward. And that really brings us onto the topic of neuroendoscopic lavage. Now, this is a procedure that's gaining popularity at the moment as a potential alternative management for neonatal IVH. And it allows the clearance of the ventricular blood products. And this, we hope, promotes shunt independence or delays the time to having to have a shunt inserted. So last year, we published a series of patients that we treated here in Oxford. And this is amongst the largest series currently available in the literature. The aims of this study were to assess the safety of our procedure, and that was through assessment of our post-operative complications, and also the efficacy of the procedure. And we looked at different ways of measuring this. So firstly, we assessed the CSF in terms of protein and cell counts before and after the washout procedure. We then looked to see, of the patients who had a washout, how many went on to require a shunt being inserted. And then of those who needed a shunt, the time between the washout and the insertion. And then finally, how long did that shunt survive without requiring a revision? We also generally assessed the patients in terms of their motor and neurocognitive outcomes to have a better holistic assessment of the patient outcomes. So we treated a total of 26 patients with post-hemorrhagic hydrocephalus, and all of our patients were grade 3 or 4 IVH. And the median age at the time of procedure was 39 weeks and 4 days. All infants weighed more than 1,500 grams, and they had to be deemed to have sufficient control of their comorbidities by an MDT of the neonatologist, anaesthetist, and the neurosurgery team. And if they were unfit for surgery, they were treated with a temporizing fontanelle tap in the meantime until they were of sufficient weight or control. So what were the results of our study? So we demonstrated that overall, our complication rates were low. So 2 patients had a CSF leak, 2 did develop post-operative infection, and a single patient did experience a very small rebleed within 72 hours of the original procedure. But these complication rates, in comparison to those of ventricular access devices or EVDs, are relatively low. There were also no episodes of mortality associated with this procedure. In terms of the biochemical success of the procedure, you can see that our preoperative red cell counts and protein levels were significantly higher than those post-operatively, which is a significant success thinking about their long-term management. The other thing, of course, that we mentioned was shunt requirement. 17 of our patients did go on to require permanent CSF diversion with a shunt. However, 9 survived without any further operations after their washout, and were completely free of any long-term insertion of prosthesis within their CNS. The other important thing is those that did require CSF diversion, the median time between the washout and then requiring that shunt was 53 days. And this allows time for those neonates to mature physiologically, and this improves the chance of shunt success when it is eventually inserted. Looking at those shunts that were inserted after washouts, the 24-month survival rate was 64.7%. And when I say survival rate, that's survival of the shunt without it requiring revision. And this is significantly improved compared to the standard reported in the literature, which sits at about 44% at 12 months. And we think that this is probably due to the fact that we've managed to reduce the protein load within the ventricular system, which stops the shunts malfunctioning. So we looked at the long-term outcomes as well, and this was in the form of gross motor function classification score for these patients. And this was available for 25 of our 26 patients. The motor outcomes achieved in our cohort are shown on the graph on the right, sorry, on the left. And it's color-coded to reflect the different grades of IVH of our patients. 14 of our patients, so over half of our cohort, were able to achieve a good motor outcome, meaning they were able to walk without limitations or with only minor limitations. And this was independent of the original grade of IVH. In terms of cognitive function, we looked at the adaptation to schooling grading for these patients, and that's summarized in the table on the right. And of our patients, 15 of the patients had this outcome measure. We were only able to assess this once the children were 4 years of age or older. And what we've shown is that 8 of our children, so over half of the patients, were able to attend mainstream schooling, either with or without curricular adaptation, which really is a success.
I think what I wanted to show you is a video of the washout, which is if you've got time, it is something which is just an eye-opener to see. So if you see, I need to share my screen in a second. I changed my sharing. Give me a couple of minutes. Share screen. I'll stop sharing and then go back to sharing. So I hope this video is playing. So this is after we encountered the ventricular system, and you can see the amount of blood that is present in the ventricular system. And this is just, you can't see any other normal structures. And at this period of time, we have got the irrigation system running with warm ringer's lactate, which runs through the system, and there's outflow for that. So you have to keep on washing this till you start seeing some semblance of normal ventricular anatomy, but that can take time. And you sometimes have to remove the clots by taking the endoscope out and reinserting that, and to try to see whether we can see some normal anatomy. But as you go along, keep on washing, you will see these things which are there. There are all kind of old blood which is coming out. That's not active bleeding from anywhere. And you can, as you start seeing more of clearance after probably a liter or more of washout. We have given 3 liters of washout with warm ringers without any consequences regarding the electrolyte imbalances or anything to this child, because this is all extravascular and does not get absorbed. The only thing you have to look at is make sure that you have got good outflow. Otherwise, you'll be putting pressure in the brain. And you can see that these are the ventricular walls which have got this layering of clot, which has been slowly washed away. I kind of give an example. It's almost like a low-grade pressure washer system which you put through the ventricular walls, and that's the choroid plexus you see. And as you see on the other side, the choroid plexus has got some hemorrhage in it. And when you go towards the foramen Munro and into the third ventricle, you can see on the other side, this is a septostomy and a clot on the other side. So you can access both the ventricles through a single hole and entirely clean out all the blood which is present. In this, most of the time you can. Sometimes you have to go twice. We have maximally gone twice to clear out all the blood and the clot, depending on the grade of the hemorrhage and the thing. And you can see on the right side here, you can see those spots. Those are the spots on the thalamus due to the blood. So those are tiny RBC clinging to the ventricular wall, and they will release the hemoglobin and cause problems. So basically, to clear that all out with the washing of the ventricular wall, you can see that as you wash along, those get cleared. And you see on the top of the picture, that's the clot which is broken down, which is in the thalamochordate groove on the other side. And that clot, over a period of time, slowly with washout and gentle aspiration with a nasogastric tube close to that clot, which is cut at the tip, we will release all that clot and cause the ventricular system to look close to normalcy. But this is what we try to achieve when we do that. If we can achieve a third ventriculostomy, which means making a hole in the front of the mammillary bodies where the CSF can flow, it is well and good. But that's not achievable in a lot of the cases. So we stop at doing the third ventriculostomy, because I don't think so the third ventriculostomy works as well as what we have seen in the other cases. So you can see that this is an example of a child who had this massive big clots, the same patient which I showed the endoscopic view of. So we went to the right side, you could see very minimal clot, but you took the clot out of the occipital horn, and the other clot which was sitting in the frontal horn was all washed out. And this is a 6-month post-op scan of the same child. You can see a bit of staining in the calothalamic groove on both sides, but there's no blood, and this child has not yet required a shunt. She's 6 months down the line, head circumference is stable, and growing and developmental as close to normal as you can say. So the future directions will be are thinking about, like a British Pediatric Neurosurgery group is trying to see whether we can have a consensus about this. And Susan is going to explain that this is what is proposed. It's called a dolphin study. But this study is mostly trying to compare ventricular access device versus ventricular subgaleal shunt without the endoscopic arm as a separate. They are one of the arms is endoscopic washout and an access device, or just an access device. But our findings and our results, I want to try a separate arm for endoscopy. We don't like to put any plastic because of the same reason that we have found very good outcomes without needing to have any access device. And you can see 15% of our patients have never needed a shunt. So we think a ventricular washout is the way forward, and things probably will move towards this area. You all know this criteria of ventricular indexes going up, and we have developed a local guidelines when the neonates are referred to us for various procedures, but they are informed to us as soon as they are diagnosed with this condition, and we go and start planning of what to do, because not all of them are fit for surgery at the immediate period, but slowly and surely we are trying to do them earlier in that period. And now even we have done someone who is less than kilo, as long as the anesthetists are happy. We would ideally like to do them in the unit, but a neurosurgical procedure doing in a unit is slightly needs more of a managerial and willingness from the different managerial and logistic reasons. So I think I've done my presentation. If you got any questions, there might be more than normal questions, please.
Thank you, Shailendra. That was absolutely fantastic. Thank you both of you very much for a very clear presentation, and fantastic to actually see the endoscopic video. I think that is very salutary to remind us that what we're seeing on the cranial scans looks like that when you go in.
Yeah, because just a small tap doesn't help it, because you're just taking 10 mils of a little bit of supernatant fluid. Unless you give a clear washout, it doesn't go away.
So I have, fortunately, by going out of the thing and coming back in, I think because I was an early adopter of going in, perhaps the Teams meeting chucks you off if you go in early. So I can see some of the questions that are coming in now. And Victoria and Sam sort of talk about similar things, really. Is there actually a standardized neurosurgical approach? How are you grouping that across all the different neurosurgical centres and the neurosurgical networks? And Sam's question followed up with, do you think this is already at the stage of becoming treatment, or is this something that needs to be done in several centres as a further trial in order to establish whether this is the correct way forwards?
We have got collaborative evidence from the DRIFT trial and other aspects that this is feasible and this is doable. The worry that neurosurgeons had is a small tiny neonate. You do a washout and you release the CSF. What is stopping that kid from having subdurals and other problems? So I think, to answer your question, I think yes, we need few more units doing it, and I think endoscopy is now with the consensus we have with the Alderhay, Ghosh. I think Manchester and Leeds, we all think that that's a good idea to use a washout. Some unit who do not do washout and just do subgaleal shunts, they will be one arm of the study. But randomization is going to be difficult, because from our unit, I very strongly believe that putting a subgaleal is not going to be helpful for my patients. So that's why I'm thinking that we could be the control arm of the endoscopy, and then we could run a parallel randomization in other units which do not do this as a routine procedure. We use the standard endoscopes. We use the same 5mm endoscopes. What you need is a good system which the fluid can go in and out. You use a small scope. I don't think it works. I haven't had any problems. If you make a linear incision and close it properly, I haven't got any CSF leaks in the ward because the pressure is low after the washout. So it does not leak and the wounds heal well. With a ventricular subgaleal device, everything else, the skin is so small. You put a device below the skin, it does not, sometimes it just erodes through because of various issues the child has. So this, I think, will be the treatment in the future, but needs to be adopted by our colleagues all over the country. I very strongly feel that this should be done as early as possible if the patient is stable enough. And I'm thinking that we should try to see whether we can have a small OR kind of thing attached to a neonatal unit where you stop the transfer and other complications associated with moving a child from a neonatal unit to a theater and back to the thing with hypothermia and other problems which can happen.
So are you talking about doing this procedure in NICUs rather than...
Yeah, I think that would be a great thing, because then you can do it anytime. You don't need to wait for a particular day when we have got lists and stuff like that. So that also eliminates a lot of factors.
Right. Okay. Thank you. And I think we've established the route that you're taking to go in. But do you want to just describe what you do to get the endoscope in, just so people understand what you're talking about?
So the endoscope goes through the same, as you do a frontal tap, it's exactly the same trajectory that goes into the ventricle. You just do a centimeter vertical skin incision over the open fontanelle and open the dura and go in. The cortical mantle is mostly thin in these children. It's about centimeter to 2 centimeters. So it's a very straightforward approach. You do not need any image guidance. If you need something, an intraoperative ultrasound, which is available in all theaters. If you don't have even a neurosurgical one, you can use an ultrasound, which is used by the anesthetist, which gives you the depth of the ventricle very easily. Earlier patients had the mean age of 39. Yes, I agree with that. But as we go along, we are doing more younger patients. And we have got further, how many?
I've got another 20 patients.
20 patients. We will be presenting in our meeting in Cork, and then that will be written up as a paper very soon.
Thank you so much. That was really fascinating to hear, and it's really nice to see how things are moving on from that original very innovative DRIFT trial and how things are moving forward. So, and I really hope that you are able to continue to collaborate across the different services together to get that answer sort of refined as much as possible.
I think I'm going to learn more on the neonatologist. That's why I want to talk to you, say that you should encourage our neurosurgeons to do that. And I'm more than happy to come and help them once in a while, and they can do it then. So it's not a procedure which should be shunned across because I haven't done it or they're not confident. It's a straightforward procedure which every pediatric neurosurgeon or anybody who uses an endoscope in neurosurgery can do it.
Fantastic. Thank you so much. We've had a very busy morning, but lots and lots of really fantastic speakers. and I hope everybody's really enjoyed it and hasn't minded that we've moved and kept things going just a little bit longer. Thank you very much to all the speakers. Really interesting talks, and I'm sure, Shailendra, you may be getting some further communications from people.
No worries at all. Absolutely. More than happy to.